Welcome to the Deep Dive. This is where we unlock some of the most intricate systems of the human body, really distilling them down into knowledge you can truly master.
That's the goal.
And today, we're taking an extraordinary journey, I think, into one of your body's most, well, tireless and maybe underappreciated heroes. The kidney.
Absolutely vital.
Right now, as you're listening, your kidneys are doing something pretty astonishing. Imagine this microscopic, highly sophisticated filtration plant processing your entire body's fluid volume. What is it? An incredible 12 times a day.
12 times, yeah. The scale is just immense.
Mhm.
And the precision required.
Exactly. How does it manage that exquisite balance? Fluids, electrolytes. It's critical for every single cell in your body. And, what happens when that perfectly tuned system goes awry?
Well, it's a real testament to the body's, relentless push for homeostasis. When that delicate balance gets disrupted, maybe by hypertension, heart failure, renal failure, nephrotic syndrome, cirrhosis, conditions like that,
Right.
the consequences aren't just uncomfortable. They can range from severe fluid retention all the way to life-threatening shifts in your plasma osmolality. Understanding this whole process and, crucially, how we can intervene pharmacologically really gives you a much deeper grasp of human physiology.
Absolutely. So our mission today is to equip you with an understanding of renal physiology and the drugs that modify it that's really on par with elite professionals in the field. We're going to unpack the intricate mechanisms, fluid balance, electrolyte balance, and then dive deep into those powerful pharmacological tools, specifically diuretics and the vasopressin system regulators. These are what medical experts use to restore that vital harmony.
We've taken a very comprehensive medical text and meticulously distilled its most vital insights specifically for this deep dive. We're aiming to push beyond just the surface, really get to those foundational principles.
So what can you expect?
Well, expect a clear but exceptionally detailed journey. We'll start by dissecting the fundamental architecture of the kidney itself. Then, we'll meticulously explore how different classes of diuretics work, where they act along the nephron, digging into the molecular mechanisms.
Okay.
And finally, we'll unravel that sophisticated vasopressin system, the body's master regulator of water homeostasis. We'll look at its synthesis, how it's regulated, and the targeted drugs, agonists, and antagonists that modulate its action.
Prepare for some truly illuminating aha moments, I think, as we delve into the what, the how, and really the why it matters for these critical biological processes and the drugs that tweak them. We're really aiming for that level of mastery today.
Okay, so let's start our deep dive with the kidney itself. It often gets simplified, I think, but to truly master this, we need to appreciate its incredible role as a master regulator. I mean, its core function is fundamentally astounding, filtering the entire extracellular fluid volume, an average of 12 times every single day. It's relentless. Each of your kidneys is essentially this dense packing of about 1 million tiny, highly specialized functional units. We call them nephrons.
Right, the nephrons.
And these aren't just passive sieves.
Yeah.
They're incredibly active, constantly working through continuous processes of secretion and reabsorption, all to precisely regulate your body's fluid volume and its crucial electrolyte content.
So what's really foundational here for that elite understanding is the absolute necessity of precise body fluid osmolality regulation. This isn't vague, right? It's tightly controlled.
Oh, exquisitely. It's controlled by an incredibly finely tuned homeostatic mechanism. This system adjusts both how much water you take in, consciously or unconsciously, and critically how much solute-free water your kidneys excrete. It's a continuous dynamic balancing act, essential for maintaining cellular integrity and function everywhere in the body.
And when that meticulous balance gets upset, well, that's when we see significant, often life-threatening clinical issues pop up. Things like hypertension, heart failure, renal failure, nephrotic syndrome, cirrhosis. They can severely disrupt this equilibrium.
Exactly. The body essentially loses its ability to effectively self-regulate fluid and electrolytes.
Yeah.
And that's precisely where diuretics come in. They act as powerful pharmacological tools to intervene.
So diuretics, their main job is?
In their most clinically useful sense, diuretics are drugs engineered to significantly increase urine flow and, critically, to increase sodium Na plus excretion. We call that natriuresis.
Natriuresis, right.
Their precise purpose is to restore fluid volume or composition back towards a healthier state in these very complex disorders. And it's imperative to grasp the gravity of imbalance here. Abnormalities in this finely tuned system can come from various sources: genetic diseases, acquired conditions, even the unintended effects of other drugs. And these imbalances can lead to profound potentially life-threatening deviations in plasma osmolality. We're talking about fundamental physiological stability here, affecting every cell.
All right, let's really unpack this further. Let's zoom right in on the nephron, that fundamental urine-forming unit of the kidney. To get that professional level understanding of how diuretics work, appreciating the architecture, the marvel of the nephron and its parts, is absolutely foundational.
Indeed it is. The journey starts, the filtration truly begins, at the renal corpuscle. You might also hear it called the Malpighian corpuscle.
Okay.
This intricate structure has two main parts. Bowman's capsule, which is like a cup-shaped epithelial sac, and nestled right inside it, the glomerulus. That's a dense, specialized tuft of capillaries.
So blood comes in.
Right. Blood, carrying all its solutes of waste products, arrives at this glomerulus via an efferent arteriole. After filtration happens, the now filtered blood exits through a slightly narrower efferent arteriole.
And the fluid that's filtered out.
That resulting ultrafiltrate, essentially raw pre-urine, collects in the space within Bowman's capsule, called Bowman's space. Then it starts its meticulously regulated journey through the long, winding, tubular part of the nephron. That's where it undergoes extensive reabsorption and conditioning. And remember, each human kidney is packed with about 1 million of these intricate, constantly active nephron units.
And that glomerular filter itself,
Uh,
you said it's not just a simple sieve. It's incredibly sophisticated, selectively permeable.
It's a remarkable piece of biological engineering, absolutely. Composed of 3 intricate layers, each playing a critical role in deciding what gets filtered and what stays behind.
Okay, what are those layers?
So first, you have the fenestrated capillary endothelial cells. They line the inside of the glomerular capillaries and have these tiny windows or fenestrations allowing small molecules through. Second, just beneath them, lies the glomerular basement membrane. It's a specialized extracellular matrix, providing structural support and acting as another selective barrier. And third, on the urinary space side, you find the filtration slit diaphragms. These are formed by specialized epithelial cells called podocytes.
Podocytes, right, with the foot processes.
Exactly. Their foot processes interdigitate, creating these narrow slits. This whole multi-layered barrier ensures exceptionally precise selective filtration. Small solutes water, essential electrolytes like sodium and potassium, waste products like urea, creatinine, they flow with the filtered water. It's a passive process called solvent drag.
Into Bowman's space.
In Bowman's space. Meanwhile, the larger stuff formed elements like blood cells, vital macromolecules like plasma proteins. They're meticulously retained by this sophisticated barrier. It's an initial sorting step of incredible precision. Ensures only what's meant for further conditioning moves into the tubular system.
So taking a step back, the nephron's overall function. It's just a marvel of efficiency and dynamic regulation, filtering huge amounts, reabsorbing vital stuff, getting rid of waste.
It's a constant high-volume operation. To really put that into professional perspective, think about these numbers. Your 2 kidneys together produce about 120 milliliters of ultrafiltrate every minute.
Wow, 120 milliliters a minute.
Yet, astonishingly, only about 1 milliliter of actual final urine is produced per minute.
So over 99% gets reabsorbed.
Over 99%. That glomerular ultrafiltrate is meticulously reabsorbed back into the body. And this level of volume management done continuously comes at a significantly high energy cost. Your kidneys, even though they're only about 0.5% of your total body weight, they consume a remarkable 7% of your total body oxygen intake.
7% for just 0.5% of body weight.
Exactly. That disproportionately high energy consumption really underscores the vital, energy-intensive, and constant nature of this whole filtration, reabsorption, and secretion process.
Okay, let's follow that ultrafiltrate now on its incredible journey, segment by segment, through the different parts of the nephron. Each section isn't just a passive tube, right? They each have highly specialized functions, unique transport characteristics. That becomes absolutely critical when we get into how different diuretic classes actually work. You need to know the plumbing to understand the drugs.
Precisely. The journey begins right after Bowman's capsule with the proximal tubule. This segment starts with a winding, convoluted path, then straightens out as it dips into the renal medulla. This is unequivocally a workhorse segment.
The main reabsorber.
Absolutely. Under normal conditions, about 65% of all the filtered sodium is reabsorbed right here. And crucially, uniquely for this segment, the proximal tubule is highly permeable to water.
Ah, okay. So water just follows the salt.
Exactly. As solutes, mainly sodium, get reabsorbed, water passively follows through osmosis. So reabsorption here is essentially isotonic. The concentration of the fluid inside the tubule stays roughly the same as plasma, even as the volume drops significantly. This really sets the stage for everything that follows.
After the proximal tubule, the fluid plunges down into the loop of Henle. Now, this segment, it's a real masterpiece of physiological design, isn't it? With distinct subsegments doing different things.
It truly is. It consists of distinct parts. The proximal straight tubule, then the descending thin limb, DTL, the ascending thin limb, ATL, and finally the thick ascending limb, TAL. Each part has a very specific complementary role in creating that concentration gradient, the gradient that allows us to excrete either dilute or concentrated urine, depending on the body's needs.
Okay, let's break down that loop meticulously. The descending thin limb, the DTL, what's its key feature?
The DTL is highly permeable to water, but critically, it has low permeability to sodium chloride and urea. So as the ultrafiltrate flows down into the increasingly hypertonic environment of the renal medulla,
Water gets pulled out.
exactly, water is osmotically drawn out of the tubule into the interstitium. This concentrates the fluid remaining inside the tubule. Now, in stark contrast, the ascending thin limb, ATL, is permeable to NaCl and urea, letting these solutes diffuse out, but it's impermeable to water.
Impermeable to water, that's crucial.
Absolutely crucial. It allows solutes to leave the tubule without water following. This starts the dilution process of the tubular fluid. Then we get to the thick ascending limb, TAL. This segment has a large and vital reabsorptive capacity. It actively reabsorbs sodium chloride, but like the ATL, it remains impermeable to both water and urea.
Still impermeable to water, so salt gets pumped out, but water stays in.
Precisely. This active transport of NaCl without water following makes the tubular fluid progressively more dilute as it ascends out of the medulla. And this segment alone, the tail, is responsible for about 25% of the total filtered now plus reabsorption. That makes it a very powerful target for diuretics.
And nestled right within that critical tail, there's a specialized sensor, isn't there? The macula densa. It's strategically placed right where the tail passes between the afferent and efferent arterioles of the same nephron. What's its job? It seems incredibly important for self-regulation.
It's a sophisticated sensor and signaling center. The macula densa continuously senses the concentration of sodium chloride as the fluid leaves the loop of Henle. If that concentration is detected as too high, maybe indicating rapid flow or impaired reabsorption upstream,
It sends a signal.
it rapidly sends a localized chemical signal, likely adenosine or ATP, directly to the adjacent afferent arteriole. This signal causes that afferent arteriole to constrict.
Which reduces blood flow into the glomerulus.
Exactly. Which in turn decreases the glomerular filtration rate, the GFR, in that specific nephron. This incredibly precise homeostatic mechanism, known as tubuloglomerular feedback, TGF, acts as a vital protective mechanism. It prevents the organism from excessive salt and volume wasting. It ensures the kidney doesn't overfilter.
And it also influences renin release.
It does. The macula densa also plays a nuanced role in regulating renin release from the adjacent juxtaglomerular cells, further linking filtration rates with systemic blood pressure regulation. It's all interconnected.
Moving beyond the macula densa, the tubule changes again, morphologically and functionally, becoming the distal convoluted tubule, DCT. Like the TL, it actively transports NaCl and is impermeable to water.
Correct. That continued impermeability to water in both the tail and the DCT is precisely why they're collectively called the diluting segment of the nephron. No matter your hydration status, overhydrated or dehydrated, the fluid leaving the DCT will always be hypertonic, significantly more dilute than your blood plasma.
Okay.
However, a key distinction for a deeper understanding, unlike the tail, the DCT doesn't really contribute to building that countercurrent-induced hypertonicity in the medullary interstitium. Its main job is further dilution, not building the core concentration gradient.
The ultimate fine-tuning, then. The final adjustments to composition and volume that happens in the collecting duct system. This sounds like where the final decisions about water are made.
Absolutely. This complex network connecting tubule, initial collecting tubule, cortical collecting tubule, outer and inner medullary collecting ducts, this is where hormonal influence absolutely takes center stage. Allows for precise control.
Hormones like aldosterone and ADH.
Exactly. The adrenal steroid aldosterone plays a key role in fine-tuning electrolyte composition, particularly governing sodium reabsorption and potassium and hydrogen ion secretion. But perhaps even more critically, vasopressin, also known as antidiuretic hormone or ADH, profoundly modulates water permeability in this segment.
And these collecting ducts pass through that really salty part of the kidney, the medulla.
They do. The more distal portions pass directly through the renal medulla, where the interstitial fluid is exquisitely hypertonic, thanks to that countercurrent multiplier system we'll discuss. Now, here's the critical difference. In the absence of ADH, the collecting duct system is virtually impermeable to water.
So you make dilute urine.
Large volumes of very dilute urine. Conversely, in the presence of ADH, the collecting duct becomes highly permeable to water. Under these conditions, water is reabsorbed passively, driven by that steep osmotic concentration gradient between the dilute tubular fluid and the hypertonic medullary interstitium. This mechanism is absolutely fundamental to our ability to conserve water and excrete concentrated urine.
Okay, that brings us beautifully to one of the most sophisticated and sometimes challenging concepts in renal physiology, the countercurrent multiplier hypothesis. This is how we concentrate urine, right? Relies on the loop of Henle's structure and specific permeabilities. This seems core to mastering renal function.
It is absolutely core. It's the fundamental, elegant mechanism by which mammals and birds achieve that remarkable feat of concentrating urine. And yes, it's entirely reliant on that unique U-shaped topography and the precisely specialized permeabilities of the different subsegments within the loop of Henle. Let's walk through it meticulously, step by step, to really nail it down for mastery. It's a self-reinforcing cycle.
Okay, lay it out.
First, active transport of sodium chloride in the thick ascending limb, TAL, is crucial. Because the TAL is water impermeable, this active transport pumps NaCl into the interstitium of the outer medulla, thereby diluting the tubular fluid as it ascends. This active pumping builds the initial osmotic gradient.
Got it. Salt pumped out, water stays in, fluid gets diluted.
Right.
Oh.
As this now dilute fluid flows from the TAL into the collecting duct system, water is extracted from it only if ADH is present. Water moves out into that progressively hypertonic medullary interstitium, concentrating the urine simultaneously.
Something happens with urea.
Exactly. Because the cortical and outer medullary collecting ducts have very low permeability to urea, urea becomes progressively concentrated in the tubular fluid as water is reabsorbed. But then the intermedullary collecting duct, IMCD, more distally, is permeable to urea.
Ah, okay. So urea diffuses out there.
Yes. The highly concentrated urea diffuses out of the tubular lumen and into the intermedulla interstitium. This interstitial urea is then effectively trapped and recirculated by countercurrent exchange in the vasa recta, those medullary capillaries running parallel to the loop. This high concentration of urea in the intermedulla is a critical component of the medullary hypertonicity.
Okay, so high urea in the medulla, how does that affect the descending limb?
Because the descending thin limb, DTL, is impermeable to salt and urea, this high interstitial urea concentration draws water out of the DTL as the tubular fluid flows down the limb. This water extraction, in turn, concentrates the NaCl within the tubular fluid in the DTL.
Concentrated salt in the DTL.
Right. Then, as that now NaCl concentrated fluid flows from the DTL into the ascending thin limb, ATL, NaCl diffuses out of the salt-permeable ATL passively, further contributing to the hypertonicity of the medullary interstitium. This whole cycle continuously builds and maintains that crucial steep osmotic gradient, allowing for maximal water reabsorption when ADH is present. It's truly a masterpiece of energy-efficient design.
That's an incredible symphony of processes within the nephron. But let's get even more granular now. How do these solutes, sodium chloride, water, others, actually move across the cell membranes of those renal epithelial cells? What are the underlying cellular molecular mechanisms driving all this reabsorption and secretion? Because this is where the drug targets really lie, right?
This is indeed where we dive into the fundamental molecular biology of renal epithelial transport. Solutes cross the complex cell membranes of these epithelial cells through a diverse array of mechanisms. You've got specific ion channels, which are passive pores, symporters, which co-transport two or more substances in the same direction, antiporters, exchanging substances in opposite directions, uniporters transporting a single substance, and simple diffusion for small lipid-soluble molecules.
And the specific transporters present and where they are located is key. Luminal versus basolateral membrane.
Absolutely critical. The specific type of transport happening in any given segment is dictated by which specific transporters are present, and crucially, whether they're embedded in the luminal membrane, the side facing the tubular fluid, or the basolateral membrane, the side facing the blood and interstitial fluid. This polarity is fundamental.
And the overarching driver for almost all this work, the primary active transport engine, is that famous sodium pump, the Na plus K plus ATPase. It's not just a simple pump, is it? It's the energetic core.
Precisely. The Na plus K plus ATPase is a formidable primary active transport protein located exclusively in the basolateral membrane of virtually all renal epithelial cells. Its operation depends on ATP. It actively pumps 3 sodium ions out of the cell, into the intercellular spaces and then the interstitium, while simultaneously bringing two potassium ions into the cell. This continuous pumping action is absolutely critical. Why? Because it establishes a strong electrochemical gradient for Na+ that's deeply directed inward across the luminal cell membrane. This gradient essentially stores potential energy that the cell then cleverly uses.
So the kidney uses that massive sodium gradient as its primary energy source for moving lots of other solutes.
Smart.
That's the brilliance of it. Sodium then diffuses passively down this steep electrochemical gradient from the tubular lumen across the luminal membrane and into the epithelial cell. And this passive movement happens through several mechanisms. You've got specific Na+ channels, you've got membrane symporters or cotransporters that harness the energy stored in the Na+ gradient to pull other vital solutes like glucose via SGLTs, phosphate, amino acids out of the lumen and into the cell.
Against their own concentration gradient sometimes.
Often against their concentration gradients, yes. And you also have antiporters like the Na+-backed H+ exchanger. This one moves a proton, H+, out into the lumen as Na+ moves down its gradient into the cell. These symport and antiport mechanisms are classic examples of secondary active transport. They don't directly use ATP, but they absolutely rely on the gradient set up by the primary active transporter, the sodium pump. Okay, so once these Na+ link symporters bring their cargo glucose, phosphate, etc. into the epithelial cell, what happens next? How do those solutes get out the other side?
Right, the action of these powerful symporters causes the intracellular concentration of their specific substrates to rise significantly inside the cell. This creates new solute gradients across the basolateral membrane. These gradients then drive the further transport of these solutes out of the cell into the intercellular and interstitial spaces. This exit step can happen through simple diffusion for permeable molecules or via other specific mediated transport mechanisms like other symporters, antiporters, uniporters, or channels, depending on the solute.
And all this solute movement into the space between the cells, that creates an osmotic difference.
Exactly. The continuous accumulation of sodium and these other reabsorbed solutes in that narrow intercellular space between adjacent cells creates a small but critical osmotic pressure differential across the whole epithelial layer.
And that small osmotic difference is what finally drives the large-scale water movement. Is that the idea?
That's precisely it. In water-permeable segments like the proximal tubule or the collecting duct, when ADH is present, water rapidly moves from the tubular lumen into these intercellular spaces, driven by that osmotic pressure differential. Water moves through specific aqueous pores, the aquaporins, in both the luminal and basolateral membranes.
Right.
Plus, some water can also sneak through the tight junctions between cells. That's the paracellular pathway, especially in leaky epithelia like the proximal tubule. This bulk water flow, often called solvent drag, also passively carries some membrane-permeable solutes along with it into that intercellular space. Any solutes that can't cross the membrane easily, well, they stay trapped in the tubular lumen and eventually get excreted in the urine, taking an obligatory amount of water with them.
And finally, after all this meticulous reabsorption into the space between and around the cells, how do all these recovered goodies, water and solutes, actually make their way back into the bloodstream to be fully reclaimed by the body?
Good question. As water and solutes keep accumulating in that narrow intercellular space, the hydrostatic pressure within that space gradually increases. This rising hydrostatic pressure provides the ultimate driving force for bulk water flow, carrying all the reabsorbed solutes out of the intracellular space into the broader interstitial space surrounding the tubules.
And then into the capillaries.
And then finally into the peritubular capillaries. These capillaries are strategically positioned, wrapping around the renal tubules, perfectly placed to pick everything up. This completes the reabsorption process, effectively returning these vital fluids and solutes to the systemic circulation. It's a highly coordinated, energetically demanding, incredibly efficient process. Really shows the kidney's mastery of transport. #5, specialized secretion and ion handling.
Okay, so beyond just the massive reabsorption of sodium in water, the kidney also plays this absolutely critical role in eliminating various organic chemicals from the body, including many drugs, toxins, and it has these highly specialized, precise ways of handling other crucial ions like chloride, potassium, calcium, phosphate, each vital for specific functions.
Indeed. Organic molecules, whether they're made by the body or come from outside, can enter the renal tubules primarily by two routes, either through that initial glomerular filtration or, for many compounds, by active secretion directly into the tubular lumen by the epithelial cells themselves.
And the proximal tubule is key for this secretion.
The proximal tubule is remarkably efficient and is a major site for this active secretion. It possesses separate, highly efficient transport systems specifically designed for organic acids and organic bases. Both of these secretory systems are powered indirectly by that basolateral sodium pump we discussed, involving complex secondary, sometimes even tertiary active transport mechanisms. They usually include a facilitated diffusion step as well.
Like the OATs and OCTs.
Exactly. For example, we now understand there's a family of organic anion transporters, or OATs like OAT1 and OAT3, that facilitate the countertransport of organic anions, like many drugs or waste products, with dicarboxylates, moving substances from the blood into the tubular cells. Similarly, for organic bases, there are specific transporters like OCTs, organication transporters, and MATES, multi-drug and toxin extrusion proteins, that handle secretion. This active secretion ensures efficient removal of many compounds, especially those that are poorly filtered or highly bound to proteins in the plasma.
What about the handling of specific anions and calcins? How does the kidney meticulously manage things like chloride, potassium, calcium, beyond just following sodium? That seems critical for balance.
Let's break down the precise handling of these key ions.
Sure.
Chloride Cl reabsorption generally parallels sodium as it's the main accompanying anion. In segments with leaky epithelia, like the proximal tubule and the thiazide, a significant amount of Cl movement happens paracellularly between the cells driven by electrochemical gradients. But Cl also crosses cell membranes via specific transporters. It can move across the luminal membrane by antiport with formate and oxalate in the proximal tubule, by symport with Na plus K plus in the TL, that's the NKCC2 symporter, by symport with Na plus in the DCT, the NCC or TSC symporter, and by antiport with bicarbonate, HCO3, in the collecting duct system via transporter called pendrin.
And getting out the other side, basolateral exit.
On the basolateral side, Cl exits via symport with K plus in the proximal tubule and TL by antiport with Na plus HCO3 in the proximal tubule, and crucially through specific Cl channels like CLCKB and CLCK1 in the TL, DCT, and collecting duct system. It's this intricate network of transporters that allows for really precise control of chloride balance.
And potassium, absolutely vital for nerve and muscle function, especially the heart. How is its balance so meticulously handled? It seems complex.
Potassium K plus handling is remarkably intricate. It involves both significant reabsorption and regulated secretion. The large majority, typically 80–90% of filtered K plus SCOM, is non-selectively reabsorbed way back in the proximal tubule, passive diffusion, solvent drag, and also significantly in the tau, largely through the paracellular pathway via proteins called claudins, and also through that NKCC2 symporter.
But then it gets secreted later on.
That's what's particularly interesting and clinically relevant. The distal convoluted tubule, DCT, and the collecting duct system then engage in variable secretion of K+ into the tubular lumen. This happens primarily via specific K+ channels like ROMK and BK channels located in the principal cells. This allows for precise modulation of K+ excretion, ensuring that urinary K+ output dynamically matches your dietary intake.
What drives that secretion?
It's largely driven by the lumen-negative transepithelial potential difference that develops in the collecting duct, as Na+ is reabsorbed through E-NESI channels. That electrical gradient pushes positive K+ ions out. Aldosterone, the hormone, also profoundly modulates this K+ secretion. Contrast that with the tail, where the lumen-positive potential difference generated by K+ recycling and Cl exit is actually a key driving force for paracellular K+ reabsorption. So that transepithelial voltage is a crucial factor, working differently in different segments.
Calcium is another one whose serum levels are incredibly tightly regulated. How does the kidney contribute to this precise control?
Around 70% of filtered calcium, Ca2+, is reabsorbed in the proximal tubule, mostly passively via the paracellular route. Another substantial chunk, about 25%, is reabsorbed by the tail, again, partly paracellularly driven by that lumen-positive potential and partly by active transcellular C2+ reabsorption. And that transcellular part is significantly modulated by parathyroid hormone, or PTH.
Okay, so PTH influences calcium in the tail. Where else?
The bulk of the remaining filtered Ce2+ is then reabsorbed in the DCT, almost entirely through a transcellular pathway. This pathway in the TL and DCT involves passive K2+ influx from the lumen across the apical membrane through specific CT+ channels, notably TRPV5 and TRPV6.
TRPV5, okay.
Once inside the cell, C2+ is then actively extruded across the basolateral membrane by a Ca2+ PT-PACE, PMCA, and also by a NAM plus MANK TF2+ exchanger, and CX, an antiport mechanism using the sodium gradient. This active, hormonally regulated transport in the DCT is absolutely critical for fine-tuning calcium excretion.
And what about phosphate, another vital one for energy, bones?
Phosphate pi is largely reabsorbed, typically about 80% of the filtered load, predominantly by the proximal tubule. This happens mainly via the Now plus bus pi importer, specifically NAPI and NAPI isoforms, which cleverly co-transports phosphate into the cell by harnessing the energy of that Now plus electrochemical gradient.
And hormones influence this too.
Yes, the activity of this importer is well known to be inhibited by parathyroid hormone, PTH, and also by FGF23, fibroblast growth factor 23. This ensures the kidney can dynamically adjust phosphate excretion based on the body's needs. Finally, just for completeness, we have to briefly mention bicarbonate, HCO3, and protons, H+. The renal tubules, particularly the proximal tubule and collecting duct, play an absolutely central role in systemic acid-base balance by reabsorbing virtually all filtered HCO3 and actively secreting protons. We'll definitely delve into those crucial processes in much more detail when we discuss the specific mechanisms of carbonic anhydrase inhibitors.
Okay, now that we've built this really solid, detailed understanding of kidney anatomy, its sophisticated functional units, transport mechanisms, let's pivot. Let's directly apply this knowledge to the realm of diuretics. What exactly are they from a clinical perspective, and how do they achieve their, well, pretty profound physiological goal?
At their most fundamental level, diuretics are simply drugs designed to increase the rate of urine flow, that's diuresis. However, to be clinically beneficial, really useful, they must also significantly increase the rate of sodium excretion, that natriuresis we mentioned, and typically the excretion of an accompanying anion, most commonly chloride, Cl.
And the main clinical goal is?
Their overarching primary clinical goal is to precisely reduce extracellular fluid volume, ECFE. They do this by effectively decreasing the total body sodium chloride content.
Now, here's where our understanding of the body's adaptive mechanisms becomes exceptionally important, because the body doesn't just sit back passively when we give a diuretic, does it? There's this powerful physiological thing called diuretic braking. That seems crucial for understanding their long-term effectiveness.
You've hit on a critical point for clinical mastery. The body possesses this remarkable, robust capacity to adapt and compensate. While continued diuretic administration certainly kicks off a sustained net deficit in total body sodium, that initial brisk natriuresis you see, it's actually finite over time.
It doesn't just go on forever.
No, because the kidneys and the body as a whole rapidly engage powerful compensatory mechanisms that ultimately bring sodium excretion back into equilibrium with sodium intake. The net clinical effect: the patient achieves a new steady state, but at a lower extracellular fluid volume and body weight. That's why you don't just continuously lose fluid indefinitely when you take a diuretic regularly.
So what are these powerful and often challenging compensatory mechanisms that cause this braking phenomenon, limiting the diuretic's long-term punch?
These are crucial, complex counterresponses that really demand our attention for a complete understanding. They include, but aren't limited to, activation of the sympathetic nervous system, which promotes sodium retention; robust activation of the renin-angiotensin-aldosterone axis, the RAS system leading to increased aldosterone and angiotensin in the second levels, both promoting salt and water reabsorption; and a decrease in systemic arterial blood pressure, which itself reduces the kidney's intrinsic pressure natriuresis response.
And changes within the kidney cells themselves.
Yes, on a cellular and structural level, you frequently see renal epithelial cell hypertrophy. The cells get bigger, and an increased expression of renal epithelial transporters in the nephron segments distal to the diuretic's main site of action.
Ah, so the downstream parts work harder.
Exactly. This adaptation effectively makes the remaining nephron segments work harder and more efficiently to reabsorb what's left, partially offsetting the diuretic's effect. There might also be subtle alterations in the activity or sensitivity to natriuretic hormones like AMP, so while diuretics initiate a significant shift in fluid balance, the body quickly and intelligently works to reestablish a new equilibrium, just at a lower fluid volume.
And beyond just fluid and sodium, it's important to realize diuretics can have much broader, often indirect effects throughout the kidney. They can significantly modify how the kidney handles other crucial triglycerides, K plus H pies, H plus A, Ca2 plus Mg2 plus, and other anions like ClHCO3, phosphate.
And they might also indirectly alter renal hemodynamics, influencing blood flow within the kidney itself. Understanding these general and specific effects across the major diuretic classes, which we'll summarize in detail as we go through each one, is absolutely foundational to applying them clinically with precision and anticipating their full physiological impact.
All right, let's truly roll up our sleeves now and dive into the specific diuretic classes. We'll start with what might seem like a more subtle class, but one that's important for certain specialized clinical situations. The carbonic anhydrase inhibitors, or CAIs, anhydrase inhibitors of carbonic anhydrase, CAIs.
Okay. The primary drugs in this class available for systemic use are acetazolamide, dichlorphenamide, and methazolamide. They're all given orally. Their mechanism and site of action are intricately linked to the enzyme carbonic anhydrase. Proximal tubular epithelial cells are exceptionally rich in this enzyme. It's strategically located both in the luminal membrane, facing the tubular fluid, and in the cytoplasm of the cells.
And this enzyme is crucial for
It's absolutely crucial for the efficient reabsorption of sodium bicarbonate, AHCO3, and for the process of acid secretion in the kidney.
Okay, for that elite understanding, let's walk through that detailed mechanism again. How exactly does carbonic anhydrase enable bicarbonate reabsorption in the proximal tubule? It seemed quite elegant.
It is an elegant, multi-step process. In the proximal tubule, the energy from the sodium gradient set up by the basolateral sodium pump is cleverly used by a sodium hydrogen, Na plus H plus antiporter, specifically NHE3, in the luminal membrane. This antiporter pumps a proton H plus from the cell into the lumen in exchange for a sodium ion entering the cell.
Okay, H plus goes out.
Right. In the lumen, this secreted H plus reacts with filtered bicarbonate, HCO3, to form carbonic acid, H2CO3. Critically, carbonic anhydrase, the brush border form, rapidly catalyzes the breakdown of this H2CO3 into carbon dioxide, CO2, and water, H2O.
CO2 then diffuses into the cell.
Exactly. CO2, being small and lipophilic, quickly diffuses across the luminal membrane through the cell cytoplasm. Inside the cell, cytoplasmic carbonic anhydrase, CAI, catalyzes the reverse reaction, CO2 rapidly reacting with water to reform H2CO3. This H2CO3 then spontaneously ionizes into H plus and HCO3. The continuous action of that Na plus H plus antiporter at the luminal membrane keeps intracellular proton levels low, driving the whole process forward.
And the bicarbonate generated inside the cell.
That newly generated intracellular bicarbonate, along with the reabsorbed sodium, gets transported out of the cell across the basolateral membrane into the interstitial space via sodium bicarbonate symporter in BCE1. The net effect is this remarkably efficient transport of NaHCO3 from the lumen across the cell into the interstitium, with water passively following, ensuring isotonic reabsorption.
So if carbonic anhydrase inhibitors block this enzyme, what are the precise consequences for this whole bicarbonate reabsorption pathway?
Carbonic anhydrase inhibitors, CAIs, potently inhibit both the membrane-bound luminal and cytoplasmic forms of carbonic anhydrase. This comprehensive inhibition can lead to a nearly complete shutdown of sodium bicarbonate reabsorption in the proximal tubule. However, there's a clinical nuance. Because there's a substantial excess of carbonic anhydrase activity in the proximal tubules, you actually have to inhibit a significant fraction of the enzyme before you see a noticeable clinical effect on electrolyte excretion.
So it's not a 1.1 effect immediately.
No. And while the proximal tubule is the major site of action, carbonic anhydrase is also involved in secreting titratable acid and ammonium in the collecting duct system. So that's a secondary side of action, contributing to their overall effects on acid-base balance.
When we look at their impact on urinary excretion, what specific measurable effects do we see with CAIs?
Inhibition leads to a rapid and marked increase in urinary bicarbonate HTO3 excretion, often reaching up to about 35% of the filtered load. This significant bicarbonate loss, combined with inhibited acid and ammonium secretion in the collecting duct, results in a distinct increase in urinary pH. It can rise to around 8, and consequently the development of a metabolic acidosis in the patient.
But some bicarb still gets rescued.
Interestingly, yes. Even with potent inhibition, about 65% of filtered bicarbonate is still rescued, indicating compensatory mechanisms. There's only a small secondary increase in chloride excretion. Bicarbonate primarily replaces chloride as the main anion excreted with sodium and potassium. Fractional excretion of sodium can hit about 5%, and potassium excretion can be dramatically increased, sometimes up to 70%, partly due to increased distal sodium delivery stimulating potassium secretion.
And these effects are self-limiting.
They are notably self-limiting. Because the resulting metabolic acidosis lowers systemic bicarbonate levels, it actually reduces the filtered load of bicarbonate presenting to the proximal tubule. At lower filtered loads, the uncatalyzed reaction of CO2 and H2O is sufficient for a significant portion of bicarbonate reabsorption, which blunts the diuretic effect over time.
And how do CAIs acting proximally impact renal hemodynamics, like blood flow and filtration rate?
By profoundly inhibiting proximal reabsorption, CAIs significantly increase the delivery of solutes, particularly sodium chloride, down to the macula densa. This increased delivery triggers that tubulo-glomerular feedback, TGF mechanism we discussed,
All right, the feedback loop.
leading to increased afferent arterial resistance. The consequence is a reduction in both total renal blood flow, RBF, and glomerular filtration rate, GFR. It's a direct negative feedback initiated by the drug's primary action.
Beyond their renal effects, CAIs also have other fascinating, clinically relevant actions elsewhere in the body, don't they?
They certainly do. In the eye, carbonic anhydrase in the ciliary processes is responsible for forming bicarbonate in the aqueous humor, contributing to intraocular pressure. So inhibiting this enzyme decreases aqueous humor formation and as a result reduces intraocular pressure. This makes them invaluable for treating glaucoma.
And CNS effects.
Acetazolamide, a common CAI, frequently causes paresthesias, that tingling or prickling sensation, somnolence, or drowsiness, clearly indicating central nervous system action. Its effectiveness in certain types of epilepsy, particularly absence seizures, is partly due to the metabolic acidosis it produces, which can alter neuronal excitability, but direct CNS actions probably contribute too.
Okay.
And finally, by interfering with carbonic anhydrase in red blood cells, CAIs increase CO2 levels in peripheral tissues and decrease CO2 levels in expired gas, subtly impacting respiratory physiology.
Pharmacokinetics, generally well absorbed orally, varying half-lives, mainly eliminated by the kidneys. So renal function is key for dosing. Now, therapeutically, they aren't typically considered high-efficacy diuretics when used alone, right?
That's an important clinical distinction. Their maximal efficacy as single agents is relatively low compared to, say, loop diuretics. However, when acetazolamide is strategically combined with diuretics that block sodium reabsorption more distally, that sequential nephron blockade strategy, it can induce a marked synergistic natriuretic response. This can be particularly helpful in patients resistant to other monotherapy,
But long-term use is limited.
often limited by the predictable development of metabolic acidosis, which diminishes their ongoing effectiveness. Their major and most common indication remains open-angle glaucoma. Topical ophthalmic drops like drosolamide and brinzolamide are frequently used, and oral acetazolamide is also an option.
Other uses?
Acetazolamide is also used for certain types of epilepsy, like absence seizures. It can help with acclimatization to high-altitude illness or mountain sickness, likely due to inducing metabolic acidosis, which stimulates ventilation. Dichlorphenamide is uniquely approved for familial periodic paralysis, and CAIs are invaluable for correcting metabolic alkalosis, especially the kind caused by diuretic-induced increases in proton excretion, plus several other off-label uses where their acidifying properties are useful.
What about toxicity, adverse effects, contraindications, drug interactions? Always crucial for safe use.
Serious toxic reactions are infrequent, but important to know for clinical mastery. These drugs are sulfonamide derivatives. So like other sulfonamides, they carry a potential risk of bone marrow depression, aplastic anemia, granulocytosis, various skin toxicities like Stevens-Johnson syndrome, sulfonamide-like renal lesions, interstitial nephritis, stone formation, and broader allergic reactions.
Common side effects.
At higher doses, drowsiness, lethargy, and paresthesias are common, indicating CNS involvement. Most adverse effects, contraindications, and interactions are directly linked to either urinary alkalinization or systemic metabolic acidosis. For example, by alkalinizing the urine and inhibiting ammonia excretion, they can divert ammonia from the urine into the systemic circulation. This can induce or worsen hepatic encephalopathy, making them absolutely contraindicated in patients with liver cirrhosis.
Right. And the alkaline urine.
Increases the risk of calcium phosphate kidney stones and ureteral colic, as these salts precipitate more easily at higher pH. They're contraindicated in patients with pre-existing hyperchloremic acidosis or severe COPD, as they can worsen the acidosis. They can also reduce the excretion of weak organic bases, potentially causing drug accumulation. And caution is specifically advised with high-dose salicylates, as the combination can lead to CNS toxicity.
Okay, let's shift gears now to the next distinct class, the osmotic diuretics. These use a very different yet equally clever mechanism. ###B osmotic diuretics.
The key osmotic diuretics available in the U.S. include glycerin and mannitol, with mannitol being the most widely used intravenously. What fundamentally defines these agents is their unique set of properties. They're freely filtered at the glomerulus, but crucially, they undergo very limited or virtually no reabsorption by the renal tubules.
And they're inert pharmacologically.
Pretty much. They don't bind to specific receptors or inhibit enzymes in the traditional sense. Their therapeutic action comes from giving them in large enough doses to significantly increase the osmolality, the concentration of solutes in both the plasma and consequently the tubular fluid.
So their main action is basically creating a powerful osmotic pull. Less about direct transport or blocking, more about physical principles.
Precisely. Their mechanism leverages fundamental osmotic forces. They act primarily in the loop of Henle, but also have effects in the proximal tubule. As non-reabsorbable solutes concentrated in the tubular lumen, they create an osmotic gradient that limits the passive osmosis of water out of the tubular lumen into the interstitial space.
Holding water in the tubule.
Exactly. In the proximal tubule, this effectively reduces the luminal sodium concentration to a point where net sodium reabsorption stops because water can't follow it out as easily. Beyond the kidney, systemically, by extracting water from intracellular compartments throughout the body due to that increased plasma osmolality.
They expand the extracellular fluid volume.
Yes, they expand the ECFE, decrease blood viscosity, and can inhibit renin release. These systemic effects also contribute to their renal actions by increasing renal blood flow. This increased renal medullary blood flow helps wash out NaCl and urea from the renal medulla, reducing that crucial medullary tonicity.
Which impacts water extraction later on.
Right. This reduction in medullary tonicity decreases water extraction from the descending thin limb, DTL, which then limits the concentration of NaCl in the fluid entering the ascending thin limb, ATL. This diminishes passive NaCl reabsorption in the ATL, further boosting their diuretic effect. Additionally, they've been shown to inhibit magnesium reabsorption in the tail.
When we look at their effects on urinary excretion, what specific changes in electrolyte output do we see? Seems like it would be pretty broad.
It is broad. Because of their osmotic effect throughout various nephron segments where water reabsorption is normally coupled to solute reabsorption, osmotic diuretics cause a non-specific increase in the urinary excretion of nearly all key electrolytes. Sodium, potassium, calcium, magnesium, chloride, bicarbonate, phosphate, they all tend to increase. This widespread effect differentiates them from more targeted diuretics.
And how do these agents, particularly mannitol, impact renal hemodynamics?
Osmotic diuretics like mannitol generally lead to an increase in total renal blood flow. The mechanisms might involve changes in intrarenal prostaglandins or direct effects on vascular resistance. However, it's important to note that total glomerular filtration rate, GFR, isn't typically significantly altered. That increased renal blood flow can sometimes limit the kidney's ability to concentrate urine by reducing the medullary gradient, but that's secondary to their main osmotic action.
Okay. ADME. Glycerin and isosorbide can be oral, but mannitol and urea usually need IV. What are their main precise therapeutic uses in practice?
One absolutely key use for mannitol is treating dialysis disequilibrium syndrome. This happens when hemodialysis removes solutes too quickly from the ECF, causing its osmolality to drop faster than the intracellular fluids. Water then rushes into cells, especially brain cells, causing cerebral edema.
Nasty symptoms, right?
Yeah.
Headache, nausea?
Yeah, exactly. Headache, nausea, muscle cramps, even convulsions or coma. Osmotic diuretics brilliantly counteract this by increasing the ECF osmolality, drawing water back out of the cells, restoring balance. Building on this, by increasing plasma osmotic pressure, they're also invaluable for acutely extracting water from the eye and brain.
So glaucoma and brain swelling.
Yes. Used to rapidly control intraocular pressure during acute glaucoma attacks and for short-term pressure reduction before and after eye surgery. Mannitol is also a mainstay for reducing cerebral edema and overall brain mass before and after neurosurgery, and critically, to control intractable intracranial pressure after traumatic brain injury.
Interesting uses. Cystic fibrosis.
Yeah, a spray-dried form of mannitol is FDA approved for managing cystic fibrosis in adults. It hydrates airways, improves mucus clearance. It's also used to diagnose bronchial hyperreactivity. While historically used for acute kidney injury, its actual efficacy in improving renal outcomes there is, well, questionable based on modern evidence. They can also be used as urologic irrigants.
Given their mechanism pulling water around, I imagine there are significant toxicities, adverse effects, contraindications clinicians must be acutely aware of.
Indeed. Since they're mainly in the ECF and significantly increase its osmolality, they rapidly pull water from intracellular compartments. This expands the ECF volume. In patients with heart failure or pulmonary congestion, this rapid expansion can tragically lead to frank pulmonary edema fluid in the lungs, a severe complication.
And the opposite can happen too, dehydration.
Yes. If water loss through diuresis exceeds electrolyte loss, the result can be hypernatremia and severe dehydration. The initial water extraction from cells can also cause hyponatremia, possibly explaining common side effects like headache, nausea, vomiting. They're absolutely contraindicated in anuric patients with severe renal disease. No urine flow means they're ineffective and potentially dangerous due to fluid overload.
Any specific risks with urea or mannitol?
Urea specifically carries risks of thrombosis or pain if it leaks out during IV administration, and it should never be given to patients with impaired liver function due to the risk of raising blood ammonia levels, potentially causing hepatic encephalopathy. Both mannitol and urea are strictly contraindicated in patients with active cranial bleeding, as the osmotic shifts could worsen it. Lastly, glycerin, unlike mannitol, is metabolized, and this can cause hyperglycemia, especially in diabetics.
Okay, moving on now to the heavy hitters. The loop diuretics. Often called high-ceiling diuretics because they're so incredibly effective. Understanding their mechanism is key to appreciating their power. ###C loop diuretics. Inhibitors of Na plus K plus 2 import.
The major loop diuretics in the U.S. include furosemide, bumetanide, ethacrynic acid, and torsemide. It's important to note the structural differences for clinical practice. Furosemide and bumetanide have a sulfonamide group, as does torsemide, a sulfonylurea derivative. Ethacrynic acid, however, is a phenoxyacetic acid derivative.
That's crucial for self-allergy.
Absolutely crucial. And yes, they're called high ceiling because their primary site of action, the thick ascending limb, TAL, of the loop of Henle, is responsible for reabsorbing a huge chunk, about 25% of the total filtered sodium load. And critically, the nephron segments downstream from the tail, the DCT, and collecting duct simply lack the capacity to rescue the massive amount of unabsorbed salt and water that comes pouring out of the tail once it's blocked.
So they hit a part of the nephron with huge capacity, and the parts after it can't compensate enough.
That's exactly it. This physiological limitation makes loop diuretics profoundly effective, far more so than drugs that only block reabsorption earlier, like in the proximal tubule.
So their precise mechanism involves directly blocking that key transporter in the tail, essentially paralyzing a significant portion of the kidney's reabsorptive power right there.
Exactly. These drugs exert their powerful effects primarily in the tail by directly and potently blocking the NAMA plus mega K plus megas 2 achial symporter. You'll see it called ENCC2, NKCC2, or BSC1. It sits in the apical luminal membrane of the tail epithelial cells. By inhibiting this symporter, they effectively bring sodium, potassium, and chloride transport in this segment to a virtual standstill. Evidence suggests they interact with the chloride binding site on the symporter.
And they affect calcium and magnesium too.
Profoundly. They inhibit the reabsorption of both calcium, Ca2+, and magnesium, Mg2+, in the TL. They do this by abolishing the lumen-positive transepithelial potential difference. This voltage, normally generated by NKCC2 action and potassium recycling, is the main driving force for the paracellular reabsorption of these divalent decations. So blocking the symporter kills the voltage, and Ca2 plus Mg2 plus reabsorption drops.
And there are different versions of this importer.
Yes, it's worth knowing there's an absorptive kidney-specific one, NKCC2, which is the target here, and a secretory housekeeping one, NKCC1, found more widely. Genetic mutations in the kidney-specific NKCC2 cause Bartter syndrome, a rare inherited disorder that mimics chronic loop diuretic use, hypokalemic alkalosis, hypertension.
What are the specific, often dramatic effects of loop diuretics on urinary excretion, given how potent they are?
They cause a profound and rapid increase in urinary sodium and chloride excretion, leading to massive diuresis. They can push sodium excretion up to 25% of the filtered load, truly high ceiling. They also markedly increase calcium and magnesium excretion, a key difference from thiazides.
Okay.
Furosemide specifically has some weak carbonic anhydrase inhibiting activity, so it might slightly increase bicarbonate and phosphate excretion, but that's secondary. All loop diuretics consistently increase urinary potassium and titratable acid excretion.
Why the potassium loss?
It's multifactorial, partly due to the massively increased sodium delivery to the distal tubule and collecting duct, which cranks up potassium and hydrogen secretion there, partly due to flow-dependent enhancement of ion secretion, partly non-osmotic vasopressin release, and partly activation of the RAS system, boosting aldosterone-mediated potassium secretion.
What about uric acid?
Acutely, they increase uric acid excretion, but chronically, they paradoxically reduce it, frequently leading to hyperuricemia, though clinical gout is actually rare. Crucially, by blocking active NaCl reabsorption in the tiles, they fundamentally mess with the mechanism that creates the hypertonic medullary interstitium. So they block the kidney's ability to concentrate urine.
And dilute urine.
They severely impair the ability to excrete dilute urine too, because the tile is a vital part of the diluting segment. So they hit both ends of the concentration spectrum hard.
How do these powerful drugs impact renal hemodynamics? This seems like an important distinction from other classes.
If you carefully prevent volume depletion, loop diuretics generally increase total renal blood flow, RBF, and can even redistribute blood flow towards the mid-cortex. The mechanism probably involves renal prostaglandins, PGs, because NAHIDEs, which block PG synthesis, can significantly blunt their diuretic response.
And crucially, unlike CAIs.
Critically, and this is a key differentiator, loop diuretics block tubuloglomerular feedback, TGF. They inhibit salt transport into the macula densa, stopping it from sensing increased flow. This means they do not decrease GFR by activating TGF. In fact, they are powerful stimulators of renin release, partly due to this TGF interference, and partly, if volume depletion occurs, through reflex sympathetic activation and direct stimulation of the intrarenal baroreceptor.
They also have some interesting actions outside the kidney, right? Which
Right.
contributes to their rapid use in emergencies.
Yes, loop diuretics, especially IV furosemide, acutely increase systemic venous capacitance. This effect, which can sometimes happen before significant diuresis even starts.
Reduces preload on the heart.
Exactly. It causes a rapid decrease in left ventricular filling pressure. This is a crucial beneficial effect for patients in acute pulmonary edema, immediately reducing fluid overload in the lungs. This action might also involve prostaglandins. Another important, sometimes severe action, especially with high doses or rapid IV infusion, is ototoxicity.
Hearing loss.
Yes, tinnitus, hearing impairment, even deafness, though it's usually reversible. Ethacrynic acid generally carries a higher risk. It's thought to be due to inhibiting the NAB plus micus K plus necus 2-sil symporter in the inner ear. Okay. ADME, highly protein-bound, but efficiently secreted into the proximal tubule by organic acid transporter to reach the TL lumen. Furosemide's oral absorption can be iffy, bumetanide and torsemide more reliable, and their short half-lives can lead to that post-diuretic sodium retention. Explain that again. Right, that post-diuretic sodium retention is a crucial clinical nuance. Because of their short half-lives, the usual dosing interval often isn't long enough to keep effective drug levels in the tubule constantly. As the diuretic concentration drops below the effective threshold, the nephrons, especially distal segments, become highly avid for sodium reabsorption, effectively clawing back some of the sodium lost earlier.
How do you manage that?
Clinically, you can mitigate it by carefully restricting dietary sodium intake, or by giving smaller doses more frequently, or even by continuous IV infusion in severe cases to maintain a more sustained effective concentration at the site of action.
Now, therapeutic uses. Acute pulmonary edema seems like one of their most critical dramatic applications.
Indeed, it's a hallmark indication. Given their rapid effect on venous capacitance and their ability to induce brisk natriuresis, they're also widely and very effectively used for chronic congestive heart failure, CHF, to reduce ECF volume and minimize congestion. In HFrEF heart failure with reduced ejection fraction loop diuretics added to standard therapy significantly reduce mortality and risk of worsening heart failure and improve exercise capacity.
Furosemide versus norsemide.
While furosemide is most common, torsemide might offer superior benefits in heart failure due to more reliable absorption and a longer half-life, potentially mitigating that post-diuretic sodium retention. For hypertension, they're not usually first line with normal kidney function, but they're often the choice for low GFR or resistant hypertension where others fail. They're also used for massive edema in nephrotic syndrome and carefully in liver cirrhosis with ascites. They can force diuresis in specific drug overdoses, manage acute hypercalcemia with saline, and sometimes used with hypertonic saline in severe hyponatremia. In chronic kidney disease, CKD, you typically need higher doses.
What about the most significant toxicities and adverse effects clinicians absolutely must monitor for, and contraindications?
The vast majority are due to fluid and electrolyte imbalance. It can be severe. Overzealous use can cause severe total body sodium depletion, hyponatremia, hypotension, reduced GFR, even thromboembolism. In liver disease patients, it can precipitate hepatic encephalopathy.
And in potassium.
The increased distal sodium delivery plus RAS activation leads to increased potassium and hydrogen excretion, frequently causing hypokalemic hypochloremic alkalosis. If potassium intake isn't sufficient, significant hypokalemia can develop. That's a critical risk for cardiac arrhythmias, especially with digoxin.
Other electrolytes.
They also cause increased magnesium and calcium excretion, leading to hypomagnesemia and hypocalcemia. The calcium loss means caution is needed in osteopenic postmenopausal women.
And the ototoxicity risk.
Yes, ototoxicity tinnitus. Hearing impairment, deafness is a serious concern, often reversible but more frequent with rapid IV infusion or with other ototoxic drugs. Furosemide infusions, for example, generally shouldn't exceed 4 mg. Ethacrynic acid carries a higher risk. Metabolic effects include hyperuricemia, gout rare, hyperglycemia infrequent, and adverse lipid changes, higher LDL triglycerides, lower HDL. Others, skin rashes, photosensitivity, paresthesias, bone marrow depression, rare, GI issues, contraindications, severe sodium volume depletion, sulfonamide hypersensitivity for the sulfa-based ones, and anuria unresponsive to a trial dose.
And drug interactions. Loop diuretics have a complex profile demanding careful consideration.
Indeed. Significant synergism of ototoxicity with other ototoxic drugs like aminoglycosides, cisplatin. Increased risk of digitalis arrhythmias due to hypokalemia, can increase lithium and propranolol levels, can worsen hyperglycemia with sulfonylureas, NSAIDs and probenecid can blunt the diuretic response to NSAIDs by blocking prostaglandins. Combining loops with thiazides leads to profound synergistic diuresis useful for resistance, and increased nephrotoxicity with amphotericin B.
Okay, let's turn now to the next class, the ubiquitous thiazide diuretics. These play a massive role, especially in managing hypertension. Hashtag D thiazide diuretics, inhibitors of Na plus lysosine.
The term thiazide diuretics is a broad pharmacological class. It includes both the original benzothiazine derivatives, the classic thiazide types like hydrochlorothiazide, and a group of structurally different but pharmacologically very similar drugs called thiazide-like diuretics, things like chlorthalidone, indapamide, metalazone. Functionally, they operate on the same principle.
Okay, for our elite understanding, where exactly do these diuretics work in the nephron, and what's their specific molecular target?
They primarily exert their inhibitory effects on sodium chloride transport in the distal convoluted tubule, DCT. While the DCT is the main target, some thiazide-likes like metalazone might have minor activity in the proximal tubule too. The transport mechanism in the DCT involves, as usual, the basolateral sodium pump creating the gradient. This energy is then harnessed by a specific Na plus natrial symporter, also called ENCC1 or TSC, in the apical luminal membrane.
The NCC transporter.
Exactly, NCC or TSC. This importer moves both sodium and chloride into the epithelial cell. Chloride then passively exits across the basolateral membrane via chloride channels, CLCKB. Thiazide diuretics precisely inhibit this specific napochlorous importer, stopping NCL reabsorption from the lumen. It's also worth knowing that aldosterone regulates the expression and activity of this importer, and genetic mutations here cause GILMAN syndrome, another rare inherited disorder mimicking chronic thiazide use, hypokalemic alkalosis, hypomagnesemia.
What are their specific effects on urinary excretion, and how do they differ from loop diuretics here?
Thiazides increase both sodium and chloride excretion, causing diuresis. However, they're generally considered only moderately efficacious diuretics. Maximal excretion is only about 5% of the filtered sodium load.
Why so much less than loops?
It's because about 90% of the filtered sodium has already been reabsorbed upstream from the DCT. There's just less left to block. Some thiazides have weak carbonic anhydrase inhibiting activity, slightly increasing bicarbonate phosphate excretion, but it's minor. Similar to loops, they increase potassium and titratable acid excretion, increase distal sodium delivery, flow effects, RAS activation.
Uric acid.
Acutely, they increase uric acid excretion. Chronically, they paradoxically reduce it due to volume contraction enhancing proximal reabsorption, often causing hyperuricemia.
Now, a crucial difference from loops regarding calcium.
Yes, a critical and clinically distinct effect of chronic thiazide use is a decrease in urinary calcium excretion. This beneficial effect happens through several mechanisms: increased proximal tubular calcium reabsorption due to volume depletion, and direct effects on the DCT, like upregulating luminal Ca2+ channels, TRPV5. This makes them valuable for certain conditions. They might cause mild magnesiuria, and long-term use can lead to magnesium deficiency.
How do they affect urine concentration and dilution?
Thiazides attenuate the kidney's ability to excrete dilute urine because they inhibit NaCl transport in the cortical diluting segment, part of the DCT. But importantly, they do not alter the kidney's ability to concentrate urine during water deprivation, as the DCT doesn't contribute to generating medullary hypertonicity.
And their impact on renal hemodynamics?
Typically little or no direct effect on total renal blood flow, RBF. They only variably reduce GFR, often due to minor increases in intratubular pressure. And critically, they have minimal influence on tubuloglomerular feedback, TGF. Their action is really focused on solute transport.
ADME, wide range of half-lives, influencing dosing. Secreted into the proximal tubule by the organic acid pathway, OATs, MRP4, so probenecid can interfere.
Therapeutically, they are widespread and foundational. Used broadly for edema CHF, liver cirrhosis, kidney diseases like nephrotic syndrome, acute glomerulonephritis. However, a key clinical point. Most thiazides, except metalazone and indapamide, are generally ineffective if GFR drops below 30-40 mmol. Not enough drug gets to the DCT.
But they're huge for hypertension.
Absolutely. Widely and effectively used for hypertension, often first line, alone, or in combination. They're inexpensive, effective, generally well tolerated, usually once daily. A cornerstone globally. And it's particularly noteworthy for deeper understanding. While hydrochlorothiazide is super common, strong evidence suggests chlorthalidone and other thiazide-likes might be superior for long-term blood pressure control and cardiovascular event reduction.
Why is that?
Likely due to their significantly longer half-lives, providing more consistent 24-hour blood pressure control. Their ability to reduce urinary calcium excretion makes them invaluable for treating calcium kidney stones and potentially for osteoporosis. Counterintuitively, they're also a mainstay for treating nephrogenic diabetes insipidus.
How do they help there? Seems odd.
They reduce the polyuria, the excessive dilute urine, by up to 50%, two main ways. Inducing mild volume contraction, which enhances proximal water reabsorption and blocking the DCT's ability to form maximally dilute urine. They can also be useful for bromide intoxication.
What about their toxicity, adverse effects, contraindications, crucial considerations?
Generally well-tolerated, serious adverse effects are rare. Infrequently cause CNS, GI, hematological, or skin issues. But they are sulfonamide derivatives, so sulfolurgic reactions can occur. Also, rare idiosyncratic acute transient myopia and acute angle closure glaucoma. Erectile dysfunction has been reported more often than with some other antihypertensives.
The most serious issues relate to
Fluid and electrolyte imbalance, ECF volume depletion, symptomatic hypotension, especially orthostatic, hypokalemia, hyponatremia, which can be fatal or near fatal, rarely, often due to excess water intake, hypochloremia, and metabolic alkalosis. Also, hypomagnesemia and, as we said, hypercalcemia. Hyperuricemia is common, though clinical gout is rare.
and metabolic disturbances, glucose, lipids.
Yes, particularly notable. Thiazides can decrease glucose tolerance, unmask latent diabetes. Complex mechanisms reduced insulin secretion, altered glucose metabolism. However, any hyperglycemia can often be mitigated by giving potassium or a K+ sparing diuretic. And importantly, the significant cardiovascular and renal benefits generally outweigh the risks of modest worsening of glucose control, even in diabetics. Thiazide-induced hypokalemia is particularly problematic as it impairs their antihypertensive and protective effects. They can also increase LDL, total cholesterol, and triglycerides, requiring monitoring. Contraindications include known sulfonamide hypersensitivity
And drug interactions.
several important ones. They can diminish effects of uricosuric agents, sulfonylurias, insulin. Conversely, can increase effects of anesthetics, diazoxide, digitalis glycosides due to hypokalemia, lithium by reducing its clearance, loop diuretics, profound diuresis, and vitamin D. Effectiveness reduced by NSAIDs, POX2 inhibitors, blocking prostaglandins, and bile acid sequestrants, binding them in gut. A potentially lethal interaction. Potassium depletion increases risk of fatal ventricular arrhythmias with QT prolonging drugs like quinidine, dofetilide, arsenic trioxide. Needs careful electrolyte monitoring.
Okay, let's move to the next crucial group, the potassium-sparing diuretics. These often work alongside the more potent classes to provide balance and prevent common side effects. #tag EK plus sparing diuretics, inhibitors of renal epithelial NAT plus channels.
The two main drugs in this class, operating via direct sodium channel inhibition, are triamterene and amiloride. Both are organic bases, specifically transported by the organic base secretory mechanism in the proximal tubule to reach their site of action. Their fundamental utility lies in causing small increases in NaCl excretion while, crucially, sparing potassium.
Making them invaluable partners for loop and thiazide diuretics.
Exactly. To counteract the potassium-wasting cheiluretic effects of those other drugs. They're often grouped with mineralocorticoid receptor antagonists under the broader potassium-sparing umbrella.
How do these drugs precisely achieve this potassium-sparing effect at the cellular level? Seems quite distinct from the previous classes.
Their mechanism is unique and targets the final common pathway for sodium reabsorption and potassium secretion. They act primarily on the principal cells in the late distal tubules and more prominently in the collecting ducts, especially the cortical collecting tubules. These cells have specialized epithelial sodium channels, ENCs, in their apical luminal membranes.
Okay, Enos.
Sodium enters the cell from the lumen through these enases, down the gradient set by the basolateral sodium pump. This sodium entry is crucial because it depolarizes the luminal membrane, creating a lumen-negative transepithelial potential difference. This negative voltage then acts as a critical driving force for the passive secretion of potassium through channels like Raman K and hydrogen ions via H+AT passes from the cell into the lumen.
So amiloride and triamterene block these Enos channels.
Directly. They bind to a specific site within the channel pore. This blockade prevents sodium entry, thereby hyperpolarizing the luminal membrane and, crucially, reducing that lumen-negative potential difference. This reduction in the driving voltage is precisely what decreases the secretion of both potassium and hydrogen ions, thus sparing potassium and hydrogen. Understanding the specific ENSC subunits, alpha, beta, gamma, and their complex regulation, including proteases that activate ENSC, is key for an advanced understanding.
So their effects on urinary excretion are relatively mild for sodium, but significant for electrolyte balance.
Correct. Because the late distal tubule and collecting duct have limited capacity compared to upstream segments, blocking sodium channels here only produces a mild increase in sodium and chloride excretion, typically around 2% of the filtered load. But importantly, this blockade reduces the excretion of potassium, hydrogen, calcium, and magnesium. Chronic administration might also decrease uric acid excretion. They have little or no direct effect on renal hemodynamics or TGF, making their action highly localized.
ADME, amiloride eliminated unchanged renally, so kidney function matters. Triamterene metabolized in the liver to an active metabolite, so liver renal failure increases risk. Therapeutically, rarely used alone.
That's absolutely right. Due to their mild natriuretic effect, seldom used as single agents. Their major indispensable utility is in combination therapy with thiazides or loop diuretics. This serves two critical purposes. First, it augments the overall diuresis and antihypertensive response by blocking sodium reabsorption at another site. Second, and most importantly, their ability to reduce potassium excretion directly helps offset the caliuretic effects of the other diuretics, helping normalize plasma K+ and reduce hypokalemia risk.
Other uses. Little syndrome.
Yes, highly effective for Little syndrome, that rare genetic disorder with ENSC overexpression independent of aldosterone. Aerosolized amiloride has shown promise in cystic fibrosis, improving mucus clearance by inhibiting excess sodium absorption in airways. And it's useful for lithium-induced nephrogenic DI, as it blocks lithium transport into collecting tubule cells.
What about toxicities, adverse effects, contraindications? Hyperkalemia seems like the big one here.
The most dangerous and potentially life-threatening adverse effect is indeed hyperkalemia. The risk is particularly high in patients already hyperkalemic or at increased risk renal failure, those on other K+-sparing drugs like MRAs, ACE inhibitors, ARBs, direct renin inhibitors, K+ supplements, even NSAIDs increase the risk. So routine and meticulous monitoring of serum potassium is absolutely essential, strictly contraindicated in hyperkalemia.
Any specific issues with triamterene?
Triamterene is a weak folic acid antagonist, so it carries a specific risk of increasing megaloblastosis likelihood in cirrhotic patients who are often folate deficient. It can also reduce glucose tolerance, cause photosensitization, and rarely interstitial nephritis and renal stones. Triamterene itself can form stones. Both drugs can cause general CNS, GI, musculoskeletal, skin, and hematological adverse effects, though less common.
Let's move to the other distinct group of potassium-sparing diuretics, the antagonists of mineralocorticoid receptors, or MRAs. Different mechanism, similar potassium-sparing outcome. FK+A sparing diuretics, antagonists of mineralocorticoid receptors, MRAs.
This crucial class includes spironolactone and eplerenone, both steroidal compounds, and the newer non-steroidal finerenone. The mechanism hinges on mineralocorticoids, primarily aldosterone, the steroid hormone from the adrenal cortex. Aldosterone's job is to promote salt and water retention and, conversely, increase potassium and hydrogen excretion by binding to specific mineralocorticoid receptors, MINRs, in target cells.
So how do these MRAs precisely work at a cellular and molecular level? It involves gene expression, right? Quite different from just blocking a channel.
This is indeed a fascinating, more complex mechanism involving gene regulation. The principal cells in the late distal tubule and collecting duct, especially the cortical collecting tubule, have cytosolic MINRs with high affinity for aldosterone. When aldosterone binds, the hormone receptor complex changes shape and moves from the cytoplasm into the nucleus.
Acts as a transcription factor.
Exactly. In the nucleus, it binds to specific DNA sequences and regulates the expression of multiple gene products. These are collectively known as aldosterone-induced proteins, AIPs. These AIPs then go on to enhance sodium reabsorption and increase that lumen negative voltage, which significantly increases the driving force for potassium and hydrogen secretion.
And the MRAs block this.
Drugs like spironolactone, eplerenone, and finerenone are competitive antagonists. They bind to the same MR as aldosterone, but crucially, their binding prevents aldosterone from binding and activating it. The MRA-MR complex is unable to induce the synthesis of those AIPs, thereby blocking all the downstream effects of aldosterone. A unique and important distinction. MR antagonists are the only diuretic class that does not require access to the tubular lumen to work. They act from inside the cell, interfering with gene transcription.
Could you elaborate a bit more on how aldosterone specifically influences Enos? You see that epithelial sodium channel and how MRAs counteract this, maybe touching on those proteins like NED4-2, SGK1, GILZ for that elite level understanding.
Absolutely. It's a beautiful example of cellular regulation. ENS is pivotal for sodium reabsorption in the collecting duct. Both its beta and gamma subunits have a specific sequence, the PY motif. This motif interacts with NED4-2, a ubiquitin ligase. Normally, NED4-2 tags ENAC with ubiquitin, marking it for degradation, limiting its activity.
Aldosterone stops this degradation.
Aldosterone dramatically increases the expression of a protein called serum and glucocorticoid-stimulated kinase 1, SGK1. SGK1 then phosphorylates and inactivates NED4-2. This prevents NED4-2 from ubiquitinating ENAC. The result: less internalization and degradation of ENAS, leading to more active ENAS in the luminal membrane, more sodium entry. Aldosterone also boosts glucocorticoid-induced leucine zipper protein, GILZ, which seems to stabilize SGK1 and further decrease a pathway, ERK, that primes ENAC for degradation. The overall effect is a robust increase in active ENAS at the surface, boosting sodium reabsorption.
And Little syndrome fits in here.
Little syndrome, that genetic disease causing severe sodium retention and hypertension, is precisely caused by mutations in the PY motif of ENAC. These mutations stop ENAC interacting with NED4-2, leading to constitutive, always-on, overexpression of ENAC that's independent of aldosterone. That's why Little syndrome responds to ENAC inhibitors like amiloride, but not to MR antagonists. The overexpression isn't driven by aldosterone in that case.
Fascinating detail. So how do MRAs broadly affect urinary excretion? And how is their efficacy tied to the body's own aldosterone levels?
Their effects on urinary excretion are quite similar to the ENAC inhibitors' mild natriuresis, sparing potassium and hydrogen. However, a critical distinction for advanced understanding. Unlike ENAC inhibitors, the clinical efficacy of ENAR antagonists is directly dependent on the levels of endogenous aldosterone. The higher the circulating aldosterone, the greater the clinical effect of the MRA, as there's more aldosterone to compete with. Like ENAC inhibitors, MRAs have little or no direct effect on renal hemodynamics or TGF.
And what about other actions, particularly the notable side effects related to spironolactone's interaction with other hormone receptors?
Spironolactone is unique among MRAs because it has significant affinity for both progesterone and androgen receptors, besides the MRVR. This cross-reactivity can lead to notable side effects: gynecomastia, breast enlargement in men, impotence, decreased libido, menstrual irregularities in women.
But eplerenone and finerenone are different.
In contrast, eplerenone and the newer non-steroidal finerenone have very low or negligible affinity for these other steroid receptors, giving them more favorable side effect profiles in this regard. High concentrations of spironolactone might also subtly interfere with steroid biosynthesis, though usually not clinically relevant at therapeutic doses.
ADME spironolactone, partially absorbed, extensively metabolized in the liver to active metabolites, like canrenone, with long half-lives, especially in cirrhosis. Eplerenone and finerenone have good oral bioavailability, metabolized by CYP3A4 to inactive metabolites, mainly hepatic elimination.
Therapeutically, MR antagonists are very often co-administered with thiazide or loop diuretics. This combination strategy is highly effective, significantly increased fluid mobilization with much less potassium disturbance. They are particularly useful for managing resistant hypertension, especially due to primary hyperaldosteronism, Conn syndrome, and for refractory edema from secondary aldosteronism, common in heart failure, hepatic cirrhosis, nephrotic syndrome, severe ascites. In fact, MRAs are often the diuretics of choice in hepatic cirrhosis with ascites, as they directly address the underlying hyperaldosteronism.
And they've demonstrated truly remarkable life-saving benefits in heart failure, haven't they? A major clinical triumph.
They absolutely have. Added to standard therapy, MRAs unequivocally reduce morbidity and mortality substantially in patients with heart failure, with reduced ejection fraction, HFrEF. Significant reductions in overall mortality, cardiac mortality, sudden cardiac death, hospitalizations, and heart failure progression. They're recommended across a wide range of HFrEF severity.
What about HFpEF preserved ejection fraction?
Their use there remains more controversial. While they can improve some diastolic function and quality of life parameters, they haven't consistently shown improved exercise capacity, mortality, or hospitalization benefits in that specific group across all studies. Beyond these, they may also reduce ventricular arrhythmias and sudden cardiac death risk. Furthermore, MRAs reduce proteinuria in chronic kidney disease, CKD, regardless of diabetes status.
And the newer one, finer known.
Finer known specifically has shown significant improvements in a composite of renal and cardiovascular outcomes in patients with CKD and type 2 diabetes. It's FDA approved to decrease risk of renal function decline, non-fatal MI, heart failure hospitalization, and cardiovascular death in adults with CKD associated with type 2 diabetes. And in 2021, got further approval to reduce risk of end-stage kidney disease, CV death, and heart failure in diabetic CKD patients.
Spironolactone's anti-androgen effects, any off-label uses?
Yes, led to its off-label use for hirsutism and acne in women, though evidence for efficacy is considered weak broadly. There's even a nuanced case report suggesting spironolactone could potentially stimulate androgen receptors in prostate cancer, highlighting the complexity of its steroid receptor interactions, emphasizes needing a comprehensive understanding.
For toxicity, adverse effects, drug interactions, hyperkalemia is clearly the principal, most dangerous risk here, similar to the ENSC inhibitors.
Yes, hyperkalemia is the paramount, potentially life-threatening risk. Strictly contraindicated in patients with existing hyperkalemia or significantly increased risk advanced renal failure, low creatinine clearance, specific limits for eplerin and finerenone, concurrent use of other K-plus MASIC drugs, K-plus supplements, ACE inhibitors, ARBs, direct renin inhibitors. Meticulous, frequent serum potassium monitoring is absolutely mandatory.
Other risks.
MRAs can induce metabolic acidosis, particularly in cirrhotic patients. Salicylates might reduce canrenone secretion, potentially decreasing spironolactone efficacy. Spironolactone can subtly alter digoxin clearance. Beyond hyperkalemia, spironolactone's specific affinity for other steroid receptors leads to the gynecomastia, impotence, decreased libido, menstrual irregularities. It can also cause GI issues, diarrhea, gastritis, bleeding, even ulcers, contraindicated in active ulcers. CNS effects like drowsiness, confusion, skin rashes. Importantly, strong CYP3A4 inhibitors like ketoconazole, itraconazole, are contraindicated with eplerenone and finerenone as they significantly increase MRA plasma levels, boosting side effects and hyperkalemia risk.
Next up, a class that, while originally developed for diabetes, has proven to have powerful, unique diuretic properties with broad cardiovascular and renal benefits. The SGLT2 inhibitors, or gliflozins, #GSGLT2 inhibitors, gliflozins.
This relatively newer class includes drugs like canagliflozin, dapagliflozin, empagliflozin, dapagliflozin here in the U.S. They were indeed initially developed and approved for managing type 2 diabetes. But their profound, multifaceted benefits on the cardiovascular and renal systems have led to a much broader appreciation of their efficacy, including their unique hybrid diuretic mechanisms.
Let's truly delve into that mechanism. How do they work at a molecular level? And what makes them a hybrid diuretic?
Their mechanism is quite elegant. SGLT2 sodium glucose cotransporter type 2 is a low-affinity, high-capacity symporter found specifically in the apical membrane of the proximal tubule, mainly the S1 segment, its physiological job. Reabsorb about 90% of the filtered glucose load from the lumen back into the cell, using the energy from the sodium gradient.
SGLT1 handles the rest.
Right, SGLT1, found more distally, handles the remaining 10%. Both use the sodium gradient to pull back large amounts of glucose, since the glomerulus doesn't retain glucose. Gliflozins are selective inhibitors of SGLT2. By blocking SGLT2, they effectively reduce filtered glucose reabsorption by up to 50%, depending on the drug and dose.
So glucose stays in the tubule and acts osmotically.
Exactly. This unreabsorbed glucose remains in the tubular lumen and acts as an osmotic diuretic, much like mannitol, creating an osmotic gradient that pulls additional water into the lumen, increasing urine volume. That's one part of their hybrid action. The second, equally important part, is that SGLT2 normally accounts for about 5% of total renal sodium reabsorption in the proximal tubule. So by inhibiting SGLT2, gliflozins also directly decrease sodium reabsorption right there in the proximal tubule, delivering more sodium downstream.
So osmotic diuresis from the glucose plus reduced sodium reabsorption.
Exactly, a dual diuretic action.
What are their specific effects on urinary excretion and, critically, on renal hemodynamics, especially thinking about diabetes?
They significantly increase urinary glucose excretion, glycosuria, leading to increased urine flow, and a noticeable increase in sodium excretion natriuresis. Importantly, they generally don't significantly affect potassium excretion, making them distinct from other diuretics regarding kaliuresis. In terms of renal hemodynamics, patients with diabetes often have glomerular hyperfiltration, increased glomerular pressure.
Which damages the kidneys over time.
Right. Gliflozins directly address this. By increasing NaCl delivery to the macula densa in the tail, they trigger tubuloglomerular feedback, TGF. This TGF activation increases preglomerular vascular resistance, thereby decreasing that damaging glomerular hypertension. Empagliflozin, for instance, has been shown to reduce renal blood flow and hyperfiltration in type 1 diabetics, lowering estimated glomerular pressure. This mechanism helps protect the glomeruli.
And beyond direct renal effects, they clearly have profound systemic actions too. Blood pressure, plasma volume.
Chronic treatment with gliflozins consistently leads to a reduction in plasma volume by about 7%, and a measurable decrease in both systolic and diastolic blood pressure. These antihypertensive effects are primarily secondary to their diuretic activity and the volume reduction. For their ADME, gliflozins are generally readily absorbed orally, highly protein-bound, have relatively long half-lives, 11 to 17 hours, allowing once-daily dosing. Major elimination is hepatic metabolism via UGT enzymes, with metabolites excreted in urine and feces.
Their therapeutic uses have broadened dramatically, far beyond just diabetes management now, right? Vital tools in cardiovascular and renal protection.
Indeed, this class represents a paradigm shift. While still central to managing type 2 diabetes, often with metformin, gliflozins have shown remarkable consistent benefits in reducing cardiovascular mortality, non-fatal stroke MI, hospitalization for heart failure, and total mortality in type 2 diabetics.
And kidney protection.
Significant, consistent renal protection across the spectrum of kidney disease in type 2 diabetics, guarding against declining function, progression to end-stage kidney disease, ESKD, death due to kidney disease, even acute kidney injury. Their antihypertensive actions and relief of glomerular hypertension are thought key contributors. There's also growing evidence for potential synergy with RAS blockers, ACE-ARBs, for enhanced protection.
Other benefits, beyond glucose and fluid.
Their protective actions on heart and kidneys likely involve multiple mechanisms: reduced hyperglycemia, decreased inflammation, reduced oxidative stress, maybe modulating sympathetic activity. Truly multifaceted. Their unique diuretic mechanism also provides strong rationale for combining them with loops or thiazides for sequential nephron blockade, especially to overcome diuretic resistance. Clinical studies are showing they augment natriuresis from loop diuretics. And, importantly, in HFR-EF patients, gliflozins reduce CV death and hospitalization regardless of diabetes status, extending their utility significantly.
What about their toxicities, adverse effects, contraindications, especially given their unique mechanism?
Due to the high urine glucose, common adverse effects include increased incidence of reproductive infections, like vaginal yeast infections and urinary tract infections, UTIs, though usually mild to moderate. Rarely, but importantly, gliflozins can induce euglycemic diabetic ketoacidosis, PDKA, even with well-controlled blood glucose. Requires monitoring ketone levels and pH.
Bone density, amputation risk.
They can reduce bone mineral density and increase fracture risk, so caution needed in at-risk patients. There's been ongoing controversial debate about a potential increased risk of lower limb amputation, particularly with canagliflozin, though meta-analyses haven't consistently reproduced this across the class. Possible tumor genicity raised in preclinical studies remains controversial and unconfirmed in humans.
Other adverse effects.
Related to their main actions: hypoglycemia, especially with insulin sulfonylureas, polyuria, dehydration, symptomatic hypotension, dizziness, thirst, dry mouth, hyperphosphatemia, hypermagnesemia, hyperkalemia, hypovolemia, strictly contraindicated in severe renal impairment, eGFR below certain thresholds, and ESRD, drug interactions. Beta blockers may mask hypoglycemia symptoms. Fluoroquinolones, ACE inhibitors, other antidiabetics increase hypoglycemia risk.
Okay, next, let's explore natriuretic peptides. These are part of the body's own endogenous system to regulate fluid and blood pressure. Fascinating stuff. Hashtag H, natriuretic peptides, inhibitors of nonspecific cation share.
Physiologically, 4 natriuretic peptides are most relevant. Atrial natriuretic peptide, ANP, brain natriuretic peptide, BNP, C-type natriuretic peptide, CNP, and uridylatin. The intermedullary collecting duct, IMCD, is recognized as a major site of action where they exert potent natriuretic effects.
Where do they come from?
ANP and BNP share a common ring structure but come from different genes and tissues. ANP and BNP primarily from the heart, released in response to atrial or ventricular wall stretch. CNP, mainly from endothelial and renal cells. Urodilatin from altered processing of the AMP precursor within the kidney itself, found in urine. They act by binding to specific natriuretic peptide receptors, NPRs, types A, B, C.
And NPRA and B have enzymatic activity.
Right, NPRA and NPRB have intrinsic guanylate cyclase activity. Ligand binding produces cyclic GMP, cGMP, as a second messenger, leading to natriuresis, vasodilation, inhibition of renin and aldosterone. NPRC is mainly a clearance receptor, removing NPs from circulation. A human recombinant form of BNP, nasiritide, was historically available therapeutically.
So how do they precisely exert their mechanism, particularly in the IMCD? How do they block sodium transport?
The IMCD is that final, crucial site for fine-tuning sodium reabsorption, handling up to 5% of the filtered load. Natriuretic peptides, NPs, act here via their cGMP signaling pathway on specific sodium transporters. Two types of sodium channels are in the IMCD. A high-conductance cyclic nucleotide-gated cation channel, CNGC, the primary pathway for sodium entry here. And it's directly inhibited by intracellular cGMP and NPs and the low-conductance, highly selective VNC.
So they mainly inhibit the CNGC channel.
Yes. While ENSC is present, most sodium reabsorption in the IMCD seems mediated via CNGC. So the primary natriuretic effect of NPs there is via inhibition of the CNGC, directly leading to increased sodium excretion.
What are their specific effects on urinary excretion and renal hemodynamics?
Nasiritide, by inhibiting sodium transport in proximal and distal nephron, with primary effect in IFCD, leads to significant increase in urinary sodium excretion, though this can sometimes be blunted by compensatory upregulation upstream. In terms of hemodynamics, while GFR might increase in healthy subjects given NPs, in heart failure patients, the GFR response to nasiritide can be variable increase, decrease, or no change, reflecting the complex interplay of systemic and renal actions.
And other non-renal actions, vasodilation.
Yes, nasiritide acutely decreases systemic and pulmonary vascular resistances, leading to reduced left ventricular filling pressure and often a secondary increase in cardiac output. These vasodilatory effects are rapid, contributing to immediate symptomatic relief in heart failure. For ADME, being peptides, they must be given IV. Nasiritide has a very short distribution half-life, 2 months, and mean terminal half-life, 18 months, needing continuous infusion. Cleared via NPCR degradation and extracellular proteases. No renal dose adjustment usually needed.
Therapeutic uses, particularly nasiritide. What's its current place? Seems like it was used for acute heart failure.
It was used for acute decompensated heart failure with dyspnea. It was shown to effectively reduce pulmonary capillary wedge pressure and improve short-term dyspnea symptoms, which are significant clinical endpoints. However, the large-scale ASCEND-HF trial, a pivotal study,
didn't show long-term benefits.
Found no significant change in either mortality or rehospitalization rates and only a small, non-significant effect on dyspnea compared to placebo. As a result, nasiritide is generally not recommended for routine use in the broad population of acute heart failure patients and is rarely used today.
And adverse effects noted. Hypotension.
The most common was symptomatic hypotension due to its potent vasodilation. There were initial concerns about potential adverse renal effects, but the ASCEND-HF trial didn't ultimately demonstrate worsening renal function, alleviating some of those concerns.
Okay, let's briefly touch on adenosine receptor antagonists, an interesting, more subtle class of diuretics, including some very common substances. Hashtag IR, adenosine receptor antagonists.
There are 4 known adenosine receptor subtypes, A1, A2A, A2B, and A3, widely distributed. A1, A2A, and A2B are particularly important in regulating renal physiology, specifically the A1 receptor expressed in the proximal tubule. Somewhat counterintuitively, its activation stimulates sodium reabsorption.
So an antagonist of the A1 receptor would logically cause diuresis and natriuresis.
Precisely. A1 receptor antagonists cause both diuresis and natriuresis, and importantly, they are also potassium-sparing, a beneficial property. Interestingly, several naturally occurring methylxanthines common dietary compounds like caffeine, theophylline in tea, theobromine in chocolate are all non-selective A1 receptor antagonists. Consequently, they produce a mild diuretic effect.
So that coffee buzz comes with a bit of diuresis.
It does. And pamabrom, an ingredient in some OTC PMS products, is a mild diuretic. Its active component, 8-bromyltheophylline, is a methylxanthine. Its diuretic action is likely mediated, at least partly, via renal A1 receptor blockade. Highlights how everyday substances interact with complex pathways.
Finally, let's look to the future. Some intriguing emerging diuretics and novel pharmacological targets. The journey of discovery in renal physiology seems truly endless. ###J emerging diuretics.
Decades of meticulous research into the intricate molecular mechanisms regulating reabsorption and secretion continue to unveil novel pathways. This ongoing discovery process is constantly opening new, exciting avenues for future diuretic targets, moving us towards even more precise, tailored therapies. For instance, recent research has identified a family of signal transduction kinases, including WNKs, so TBH-OSR1, that play crucial roles in regulating the activity or expression of major symporters, like NKCC2 and NCC or ENAC.
So inhibitors of these kinases could be new diuretics.
Potentially, yes. Inhibitors of these specific kinases might become a new generation of useful diuretics, offering highly targeted mechanisms.
What about novel ion channel blockers?
Yes, detailed understanding of ion channels is also revealing possibilities. Transport in some renal cells fundamentally requires activity of specific channels or transporters. For example, basolateral chloride channels, CLCKB, apical potassium channels, KIRA 1.1 RMK, basolateral potassium channels, KIR 4.1, or basolateral chloride bicarbonate antiporters, pendrin, are all critical. Developing specific blockers for these could yield novel diuretics with unique, potentially advantageous properties, offering highly precise interventions.
Anything else on the horizon?
There are intriguing compounds like adimetoguanosine and adimetoguanine. They show a unique profile, increasing sodium and glucose excretion while simultaneously and markedly reducing potassium excretion, likely due to inhibiting purine nucleoside phosphorylase. The field is constantly evolving. Potential for more targeted, more effective, safer diuretic options, moving closer to that ideal of personalized medicine.
We've covered an immense amount of ground, from molecular mechanisms to detailed actions of specific drug classes. Now let's bring it all together. Apply this mastery to the practical realm, the art of diuretic therapy in clinical practice, including strategic approaches and that significant challenge of diuretic resistance.
Absolutely. Understanding the specific sites and precise mechanisms of action, as we've meticulously explored, isn't just academic. It's absolutely foundational for any clinician aiming for elite professional practice. It's not just prescribing a pill, it's deeply comprehending exactly where and how that drug is influencing the intricate tapestry of renal function and overall fluid homeostasis.
Our source material lays out those remarkably complex interrelationships, cardiovascular system, kidneys, CNS, capillary beds, powerfully illustrating how a disturbance in one area can cascade and profoundly affect all others. It also reemphasizes that fundamental, critical law of pressure natriuresis. Sodium excretion is a steep, nonlinear function of mean arterial blood pressure, MEBP.
Meaning even small BP increases can markedly boost sodium excretion, reflects the kidney's own autoregulation. And that pressure-natriuresis relationship is central to understanding fluid balance. The net change in total body sodium is simply dietary intake minus urinary excretion and other minor losses. When this delicate balance gets disrupted, edema excess fluid accumulation can form through several specific interconnected mechanisms.
Such as?
A rightward shift of the renal pressure natriuresis curve kidney excretes less sodium at a given BP. Excessive dietary sodium intake, overwhelming the kidney. Increased ECFV distribution to specific spots, peritoneal cavity causing ascites, lungs causing pulmonary edema. Increased fluid in the venous circulation causing venous congestion. Peripheral edema from altered Starling forces at the capillary level like low plasma proteins and nephrotic syndrome, and increased MAP resulting from sensed ECFV on the arterial side.
So when clinicians face a patient with edema, there are essentially three core interconnected strategies to effectively mobilize that excess fluid, an art of combination and precision.
That's right. First, ideally, correct the underlying disease if possible, address the root cause. Second, rigorously restrict dietary sodium intake. Always a crucial adjunct therapy, reduces the daily salt burden. And third, often most immediate, the judicious administration of diuretics. These effectively left shift the pressure-natriuresis relationship,
allowing the kidney to excrete more sodium and water at a given pressure,
or maintain a lower pressure for the same sodium excretion. The clinical situation, its urgency, patient factors truly dictates the precise diuretic regimen, type, dose, route, oral versus IV, desired speed of mobilization. For instance, massive pulmonary edema in acute heart failure is a medical emergency demanding rapid, aggressive 5E loop diuretic therapy. Oral wouldn't cut it.
versus mild chronic heart failure.
Exactly. For mild chronic heart failure with more subtle congestion, careful, individualized titration of oral loop or thiazide diuretics is generally preferred, aiming for gradual, sustained fluid removal. And it's vital to highlight, Loop diuretics, thiazides, and MRAs have all been shown in large trials to significantly reduce morbidity and mortality in heart failure, underscoring their profound impact beyond just symptom relief.
And for specific conditions like cirrhosis with ascites or chronic renal failure, the approach differs significantly, requires specialized knowledge.
Indeed. For cirrhotic patients with ascites, periodic administration of a combination, typically loop plus MRA, can effectively reduce the need for repeated paracentesis, improving comfort and preserving protein. In chronic renal failure, with reduced nephron mass, higher, often escalating doses of powerful loop diuretics are usually needed, as remaining nephrons are less responsive. In nephrotic syndrome, however, the diuretic response is often unfortunately disappointing. Various mechanisms, avid proximal reabsorption, albumin binding of diuretics in the tubule.
And if the edema isn't immediately life-threatening?
When edema doesn't pose immediate risk, like stable chronic renal failure or compensated cirrhosis, it's generally best practice to aim for only partial, slow removal. Use a diuretic regimen that minimizes profound physiological perturbations and electrolyte imbalances. Gradual is safer.
Now let's tackle one of the most challenging aspects for any clinician. Diuretic resistance. What exactly is it? And what are the multifaceted factors contributing to this significant clinical problem?
Diuretic resistance is rigorously defined as the situation where a patient has inadequate diuresis or natriuresis despite getting what should objectively be an adequate diuretic regimen, often high doses or combinations. It's a major clinical challenge, frequently complicating management of advanced heart failure, cirrhosis, CKD. Many factors can contribute, requiring a systematic approach.
Okay, break down those factors.
We can broadly categorize them. First, pre-nephron factors that impair diuretic delivery or efficacy before the drug even reaches its site of action. Things like reduced total renal blood flow, less drug delivered. Hypoalbuminemia, low plasma albumin, reduces efficacy of highly protein-bound diuretics by decreasing free concentration for secretion. Excessive dietary sodium intake simply overwhelming the diuretic. And very commonly and often preventable, co-administration of NSAIDs.
NSAIDs are a big one.
A frequent culprit. They inhibit renal prostaglandin synthesis. Renal PGs normally counteract some of the RAS activation and sympathetic activity diuretics induce, helping balance saltwater excretion. By blocking these PGs, NSAIDs promote saltwater retention, profoundly opposing diuretic action.
And factors within the nephron itself, directly impairing effectiveness.
Yes, intranephron factors are also critical. Increased proximal tubular sodium reabsorption, less sodium, and drug reach distal target sites. Reduced GFR impacts filtered sodium and diuretic delivery, especially for filtered drugs. Conditions like albuminuria. In chronic renal failure, not only is delivery reduced by lower RBF, but accumulating endogenous organic acids can compete with loop diuretics for transport into the proximal tubule via OATs, diminishing diuretic concentration at the active site. In nephrotic syndrome, diuretics combine to luminal albumin, reducing free concentration.
And changes in the loop or after it?
Yes, factors affecting the loop of Henle, like decreased TEL responsiveness, perhaps due to chronic transporter downregulation. And post-loop of Henle factors are particularly important compensatory adaptation. Chronic, high-dose diuretic use, especially loops, can lead to hypertrophy and hyperfunction of the DCT in collecting duct cells. These downstream segments, facing increased sodium load, respond by boosting their reabsorption capacity and number of transporters, effectively compensating for the upstream blockade and leading to resistance.
So faced with this complex challenge of diuretic resistance, what are the proven, precise strategies clinicians use to overcome it and restore effective diuresis?
Several systematic options, often combined. Simple bed rest can sometimes restore responsiveness by improving renal circulation, reducing sympathetic tone. You can increase the dose of the loop diuretic, but only up to its ceiling dose. Beyond that, nothing's gained. For drugs with short half-lives, giving smaller doses more frequently, or in acute severe cases, continuous high-V infusion of a loop diuretic can help maintain a consistently effective concentration at the active site longer, overcoming post-diuretic sodium retention.
Combination therapy, sequential blockade.
A remarkably powerful and often highly effective strategy. Strategically using two diuretics that block sodium reabsorption at different sites in the nephron leads to synergistic interaction because compensatory reabsorption downstream is simultaneously inhibited. For example, combining a loop with a K plus sparing or a thiazide diuretic can significantly improve response and manage potassium. A thiazide with recognized proximal effects like metalazone is particularly well suited with the loop, addressing both proximal compensation and distal reabsorption. Crucially, never combine two drugs of the same type or mechanism.
Other strategies.
Diet timing. Other important, often overlooked strategies. Rigorous dietary sodium restriction directly diminishes the burden, reduces post-diuretic retention, and strategically timing diuretic administration shortly before food intake when salt load is highest to maximize effect during peak sodium excretion.
Okay, moving from the intricate world of diuretics to the equally vital, elegant topic of water balance. Let's introduce vasopressin, the body's primary, most sophisticated water steward. This hormone is truly central to maintaining blood osmolality.
Arginine vasopressin, AVP, universally called antidiuretic hormone, or ADH in humans, is indeed the quintessential hormone that precisely regulates body fluid osmolality. It's synthesized in specialized neurosecretory neurons in the hypothalamus, then released from the posterior pituitary gland.
What are the specific physiological triggers that kick off its secretion? Key to understanding its role.
Its release is primarily, most potently triggered by two main physiological stimuli. First, an increase in plasma osmolality. Typically when water deprivation makes your blood more concentrated, signals a need to conserve water.
Makes sense. And the second?
Second, it's powerfully stimulated when the cardiovascular system is significantly challenged by conditions like hypovolemia, low blood volume, or hypotension, low blood pressure. Indicates the need to maintain circulatory integrity. Vasopressin's primary renal action, fundamental to water homeostasis, is to significantly increase the collecting duct cell membrane permeability to water.
Letting water move back into the body.
Exactly. Increased permeability allows passive water movement from the tubule lumen down that steep osmotic gradient we talked about into the extracellular compartment, effectively conserving free water and concentrating the urine.
But vasopressin is much more than just a water hormone. It has a remarkable array of actions far beyond just regulating fluid.
Absolutely. While its role in water homeostasis is paramount, vasopressin is also a potent vasopressor and vasoconstrictor. It can constrict blood vessels. Furthermore, it functions as a critical neurotransmitter and neuromodulator within the CNS, influencing a wide range of processes, including regulating ACTH secretion from the pituitary, cardiovascular regulation, temperature control, various other visceral functions.
And it affects blood clotting.
Intriguingly, yes. It uniquely promotes the release of specific coagulation factors, notably factor VIII and von Willebrand factor by vascular endothelium. And it can increase platelet aggregability. Plays a subtle yet significant role in blood clotting. This multifaceted role underscores its systemic importance.
To truly appreciate the physiological power and clinical relevance of vasopressin, we need to master the intricate system that synthesizes and regulates it. Let's look at the precise anatomy, the synthesis process, and its meticulous regulation.
The body's sophisticated antidiuretic mechanism involves two anatomically distinct, yet functionally integrated components: a central nervous system, CNS component, and a renal collecting duct system. The CNS part is the hypothalamo-neurohypophyseal system.
Okay, what does that involve?
It comprises specialized neurosecretory neurons, mainly in two hypothalamic nuclei, the supraoptic nucleus, SON, and the paraventricular nucleus, PVN. Long axons from the magnocellular neurons in these nuclei extend down, forming the hypothalamo-hypophyseal tract, and terminate directly in the neural lobe of the posterior pituitary, the neural hypophysis.
And that's where it's released into the blood.
Exactly. It's from these nerve terminals that vasopressin and oxytocin are released directly into the systemic circulation. The second component is the renal collecting duct system, which, as we discussed, contains the specific receptors that respond to this released vasopressin by profoundly increasing water permeability.
How is vasopressin actually synthesized at a molecular level? A pre-prohormone, precise cleavage? Sounds complex.
Vasopressin, along with oxytocin, is mainly synthesized in the cell bodies of those magnocellular neurons in the SN and PVN. Though for completeness, some parvocellular neurons in the PVN and even certain non-CNS cells, heart, adrenal gland also synthesize vasopressin, indicating broader local roles. Its synthesis seems primarily regulated at the transcriptional level, controlling the amount of mRNA.
And the precursor molecule.
In humans, vasopressin synthesis starts as a much larger 168 amino acid precursor, a preprohormone. It's structured with three distinct domains linked sequentially: vasopressin peptide itself, then vasopressin neurophysin, finally vasopressin glycopeptide, separated by enzymatic processing signals.
Processed during transport down the axon.
Right. Inside specialized secretory granules, as the preprohormone travels down the axon, a series of precisely acting enzymes cleave and modify it. This meticulous processing ultimately yields the mature, active vasopressin peptide, a carrier protein called vasopressin neurophysin, or neurophysin chloride, and vasopressin glycopeptide. The vasopressin neurophysin part is particularly crucial. It binds non-covalently to vasopressin and is absolutely critical for correct processing, efficient axonal transport, and proper storage in the vesicles.
So mutations there cause problems.
Yes, genetic mutations in the signal peptide or the nerve-fissin region are well-known causes of central diabetes insipidus, underscoring its vital role.
You mentioned extra CNS synthesis. What roles do these local vasopressin production sites play?
They highlight vasopressin's multifaceted local roles. In the heart, for instance, conditions causing high-wall stress, like heart failure, significantly increase local vasopressin synthesis. This local cardiac vasopressin might contribute to impaired ventricular relaxation, even cause coronary vasoconstriction, potentially worsening cardiac dysfunction. In the adrenal gland, vasopressin made in the medulla might stimulate catecholamine secretion and promote adrenal cortical growth, even stimulate aldosterone synthesis. Further links to stress responses and electrolyte balance.
Now, the regulation of its secretion is extraordinarily complex, but a profound understanding starts with recognizing that hyperosmolality is the absolute principal physiological stimulus.
Yes, an increase in plasma osmolality is the most potent, precise physiological stimulus for vasopressin secretion. Reflects the body's need to conserve water. There's a very specific osmolality threshold for secretion, typically around 280 mmHg. Below that, vasopressin levels are barely detectable.
But above it.
Above this threshold, plasma vasopressin levels show a remarkably steep, relatively linear relationship with plasma osmolality. A mere 2% rise above threshold can trigger a rapid 2 to 3-fold increase in circulating levels. This dramatic increase, in turn, leads to increased solute-free water reabsorption in the kidney and a significant rise in urine osmolality, effectively conserving water.
And thirst kicks in later.
As plasma osmolality climbs higher, typically above 290 mOs in kilom, it also activates separate neural pathways, triggering intense thirst. So the vasopressin system not only allows longer thirst-free periods by maximizing water reabsorption, but if water isn't available, it helps ensure survival during water deprivation by minimizing urinary water loss. It's important for mastery to note, above about 290 mL in kilom, vasopressin levels usually exceed 5 ppm, where urinary concentration is already maximal. Further defense against hypertonicity then depends mainly on actual water intake, not further cuts in urine water loss.
And there's also that fascinating mechanism with hepatic portal osmoreceptors, an anticipatory signal.
Correct. Illustrates the body's anticipatory regulation. An acute oral salt load, even before it significantly raises systemic osmolality, can rapidly activate specialized osmoreceptors in the hepatic tortal circulation. This activation prompts vasopressin release, priming the system to conserve water before the systemic osmolality rises. A rapid anticipatory response helping mitigate the hypertonic challenge efficiently.
Hypovolemia and hypotension also powerfully trigger vasopressin release, but the regulation here is exponential, not linear, more like an emergency response.
That's a crucial distinction for understanding its physiological hierarchy. Small decreases, maybe 5% in blood volume or pressure, have little effect. But larger, severe decreases, say 20–30%, can cause plasma vasopressin to skyrocket 20 to 30 times normal. These exceedingly high levels far exceed what's needed for maximal antidiuresis.
So it acts as a vasoconstrictor then?
In such severe hypovolemic or hypotensive states, vasopressin acts as one of the body's most potent endogenous vasoconstrictors. Helps prevent cardiovascular collapse by increasing systemic vascular resistance. Importantly, this hemodynamic regulation doesn't disrupt osmotic regulation. Rather, severe hypovolemia-hypotension actually shifts the set point for osmotic release to a lower osmolality and increases the slope of the osmolality-vasopressin relationship. This adjustment prioritizes blood pressure maintenance over pure osmolality regulation in life-threatening situations.
What are the intricate neuronal pathways involved in this hemodynamic regulation, linking blood pressure volume sensors to the hypothalamus?
Complex and multi-layered. Baroreceptors, specialized stretch receptors, are central. Low-pressure ones in the left atrium, ventricle, pulmonary veins sense blood volume filling pressures. High-pressure ones in the carotid sinus, aortic arch monitor arterial blood pressure. Nerve impulses from these travel mainly via vagal and glossopharyngeal nerves to brainstem nuclei, like nucleus tractus solitariae. These nuclei then relay crucial info to the SN and PVN in the hypothalamus, modulating vasopressin secretion in response to circulatory status.
And how do other hormones and neurotransmitters, stimulatory and inhibitory, modulate vasopressin secretion, painting a broader picture of integrated control?
Vasopressin synthesizing neurons are exceptionally complex, with a vast array of receptors on cell bodies and nerve terminals. Allows incredibly diverse chemical modulation. While the precise interplay is multifaceted, key stimulators include acetylcholine, histamine, dopamine, glutamine, aspartate, CCK, NPY, substance P, VIP, prostaglandins like PGE2, and angiotensins II. Important physiological inhibitors include atrial natriuretic peptide, AMP, GABA, and opioids, especially dynorphin via kappa receptors. Angiotensin II's effects have gotten lots of attention. Both brain-synthesized angiomirror, neurotransmitter, and circulating Ang, crossing blood-brain barrier at certain spots, can directly stimulate vasopressin release. Some evidence suggests angiotensin III might be the main effector peptide in the brain, RAS controlling vasopressin release.
What about pharmacological agents? Stimulating or inhibiting vasopressin, sometimes with unintended effects.
Several drugs can indeed alter urine osmolality by directly or indirectly stimulating or inhibiting vasopressin secretion, often through mechanisms not fully understood. Drugs known to stimulate vasopressin secretion include vincristine, cyclophosphamide, tricyclic antidepressants, nicotine, powerful stimulus, epinephrine, high-dose morphine. Interestingly, lithium, which inhibits vasopressin's renal effects, also seems to enhance its secretion.
And inhibitors.
Conversely, pharmacological inhibitors include ethanol, alcohol classic diuretic, phenytoin, low-dose morphine, glucocorticoids, fluphenazine, haloperidol, promethazine, oxylorphin, butorphanol. Carbamazepine is interesting and complex. Known renal action enhancing vasopressin response, antidiuresis in central DI, but paradoxically also inhibits vasopressin secretion via central actions, highlights the multifaceted nature of drug effects on neurohormonal systems.
It's abundantly clear vasopressin has this wide, complex array of physiological effects, extending far beyond simple water retention. How are these diverse actions meticulously mediated at the cellular level? This is where understanding its receptor subtypes becomes critical for mastery.
Cellular vasopressin effects are precisely mediated by its interaction with three distinct types of G protein-coupled receptors, GPCRs, each with unique signaling pathways and tissue distributions. V1A receptors, V1B receptors, and V2 receptors.
V1A, where are they found?
The V1A receptor is the most widely distributed, ubiquitous subtype, found extensively in vascular smooth muscle, mediating vasoconstriction, adrenal gland, myometrium, uterine muscle, bladder, fat cells, liver cells, platelets, renal medullary interstitial cells, vasa recta in the kidney, influencing blood flow, epithelial cells in the cortical collecting duct, role still being figured out, spleen, testes, and numerous CNS structures where it acts as a neurotransmitter.
V1B, more limited.
V1B receptors have a more limited, specialized distribution, predominantly in the anterior pituitary, mediating ACTH release, several key brain regions, pancreas, and adrenal medulla.
And V2, primarily kidney.
Finally, the V2 receptors are predominantly and crucially located in the principal cells of the renal collecting duct system, where they mediate the primary antidiuretic effect. But they're also present on epithelial cells in the thick ascending limb, TAL, and on vascular endothelial cells, where their role in releasing coagulation factors is important.
Let's meticulously detail the V1 receptor effector coupling. What signaling pathways get activated? What are the immediate and broader consequences?
When vasopressin binds and activates V1A or V1B receptors, it typically couples to the GQ protein. This activation stimulates phospholipase C, PLC, an enzyme that hydrolyzes PIP2 into two crucial second messengers, IP3 and D-Day.
IP3 and D-Day, what do they do?
IP3 mobilizes intracellular calcium, Ca2+, from storage, leading to a rapid transient rise in cytosolic Ca2+. D-Day activates protein kinase C, PKC. The combined action of increased Ca2+ and activated PKC leads to a diverse range of biological effects. Immediate, rapid responses like robust vasoconstriction, V1A, glycogenolysis in the liver, V1A, platelet aggregation, V1A, and ACTH release from the anterior pituitary, V1B. Furthermore, V1A activation also plays a role in cell growth responses in smooth muscle and can stimulate production of eicosanoids, like prostaglandins. This complex cascade underscores the multifaceted, rapid actions of V1 receptors.
And the V2 receptor, obviously absolutely critical for its profound antidiuretic effects. Let's delve into its specific signaling pathway. How does it mediate water and urea reabsorption?
Absolutely. V2 receptors are strategically on the basolateral membranes of collecting duct principal cells. When vasopressin binds, they couple predominantly to the G's protein. This activation stimulates adenyl cyclase, the enzyme converting ATP to cyclic AMP.
CMP increases,
Absolutely.
reactivates PKA.
Right. Increased intracellular KMP activates protein kinase, A, PKA, the key downstream effector. PKA initiates a phosphorylation cascade triggering two critical coordinated cellular responses. First, it increases the insertion rate of performed water channel-containing vesicles, specifically those of aquaporin 2, AQP2, into the apical membrane. Simultaneously, pKa activation decreases the endocytosis rate, internalization, of these AQP2 vesicles from the apical membrane.
That effect, more AQP2 channels in the membrane.
Exactly. This net shift of AQP2 channels into the apical membrane rapidly increases water permeability, allows significant passive water reabsorption from the lumen into the cell, then into the interstitium, down the osmotic gradient.
But V2 activation has even more intricate effects for complete understanding. Urea, sodium.
Yes. It also significantly increases urea permeability by up to 400% in the terminal parts of the intermedullary collecting duct, primarily by activating a vasopressin-regulated urea transporter, VRUT, or UT1-UTA1, likely via pKa phosphorylation. While urea transport kinetics differ from water, no vesicular trafficking like AQP2, this enhanced urea reabsorption is vital for building that high urea concentration in the intermedullary interstitium, crucial for the countercurrent multiplier.
And sodium transport.
Furthermore, V2 activation subtly but importantly increases sodium transport in both the TL and the collecting duct. In the TL, it affects the NKCC2 symporter via 3 mechanisms: rapid phosphorylation, translocation into the luminal membrane, and increased protein expression. All these multiple mechanisms increasing water permeability, enhancing urea transport, modulating sodium transport work synergistically to profoundly enhance renal water conservation and the kidney's ability to make concentrated urine.
And how do aquaporins, these specialized water channels, fit into this picture? Distinct roles in different nephron parts, especially AQP2.
Aquaporins are a family of highly specialized membrane proteins acting as water channels, facilitate rapid passive water diffusion. Distinct structure, form tetramers, creating selective water pores, excluding solutes. In the kidney, at least 7 different aquaporins are expressed at distinct sites.
AQP1, where is that?
Aquaporin 1, AQP1, is abundant in apical and basolateral membranes of the proximal tubule and descending thin limb. Essential for bulk, unregulated water reabsorption, crucial for initial urine concentration phases. However, aquaporin 2, AQP2, is the major, uniquely vasopressin-regulated water channel.
Exclusively in the collecting duct system.
Exclusively in principal cells of the connecting tubule and collecting duct. Its trafficking, movement to from membrane, and expression are meticulously, rapidly regulated by vasopressin, allowing dynamic control of water permeability. Once water enters via AQP2, it exits across the basolateral membrane into the interstitium through aquaporin 3, AQP3, and aquaporin 4, AQP4.
Okay.
These are constitutively expressed on basolateral membranes, serving as exit pathways. Other aquaporins like AQP7 are present, roles still being explored. This precise spatial and functional distribution is fundamental to regulating body water.
Let's meticulously delve into the specific renal and non-renal actions of vasopressin. It's clear this hormone orchestrates a true symphony of effects across multiple organ systems, far beyond just its antidiuretic role.
In the kidney itself, vasopressin's actions are mediated by both V1 and V2 receptors, sometimes with opposing or complementary effects. V1 receptor-mediated actions within the kidney include contracting mesangial cells in the glomerulus, influencing filtration, and contracting vascular smooth muscle in the vasa recta, medullary capillaries, and efferent arterioles.
Constricting medullary blood flow helps concentration.
Yes, this contributes to maximum urine concentrating capacity by reducing suitin washout from the inner medulla. V1 receptors also stimulate prostaglandin synthesis by medullary interstitial cells. Since PGE2 can inhibit adenyl cyclase in collecting ducts, this might actually serve as a local counterbalance to V2-mediated antidiuresis and negative feedback. Furthermore, V1 receptors on principal cells in cortical collecting ducts might even inhibit V2-mediated water flux via PKC activation.
And for V2 receptors, what's their primary, most clinically significant impact in the kidney beyond just water channels?
V2 receptor-mediated actions are the most prominent and clinically recognized response. A dramatic, rapid increase in collecting duct water permeability. This happens at very low plasma vasopressin concentrations, much lower than needed to activate V1 receptors. Beyond this, other V2-mediated renal actions include significantly increasing urea transport in the intermedullary collecting duct via VRUT and subtly increasing sodium transport in the TAL. Both these latter effects crucially contribute to concentrating ability by enhancing the medullary osmotic gradient.
Synergizing with aldosterone.
V2 receptors might also subtly increase sodium transport in cortical collecting ducts, potentially synergizing with aldosterone to enhance overall sodium reabsorption, especially during hypovolemia. This interplay ensures efficient water and salt conservation.
It's fascinating how its antidiuretic response can be pharmacologically modified by other drugs, enhancing or inhibiting its action.
Indeed, a key aspect for clinical understanding. NSIs, especially indomethacin, are well known to significantly enhance the antidiuretic response to vasopressin,
Why? Blocking prostaglandins.
primarily because renal prostaglandins normally attenuate vasopressin's effects by inhibiting adenyl cyclase, and NSAIDs inhibit prostaglandin synthesis, removing this inhibitory brake. Drugs like carbamazepine and chloropropamide also enhance vasopressin's effects, sometimes leading to water intoxication with chloropropamide, though mechanisms aren't fully clear. Conversely, several drugs inhibit vasopressin's antidiuretic actions. Lithium acutely reduces V2-mediated adenyl cyclase stimulation and also increases PTH levels, which can partially antagonize vasopressin. The antibiotic dimeclocycline also attenuates vasopressin's effects, probably by reducing CAMP accumulation and action, independent of lithium.
Moving beyond the kidney, vasopressin clearly has significant non-renal actions, starting with complex, often nuanced cardiovascular effects.
Its cardiovascular effects are undeniably complex, concentration-dependent. Vasopressin is a potent vasoconstrictor via V1a receptors, affects resistance vessels throughout the circulation. Skin, skeletal muscle, fat, pancreas, thyroid are exquisitely sensitive. Significant constriction also in GI tract, coronary vessels, brain.
But the pressor response in vivo is often minimal.
Despite this direct potency, vasopressin-induced pressor responses in the living organism are generally minimal under normal conditions, typically only apparent at concentrations much higher than needed for maximal antidiuresis. This paradox is largely due to vasopressin's CNS actions, via V1, inhibiting sympathetic outflow and potentiating baroreflexes, counteracting its direct vasoconstriction. V2 receptors also cause vasodilation in some vessels. However, vasopressin plays a vital, life-saving role maintaining arterial pressure during severe hypovolemia hypotension, a crucial emergency pressor.
Effects on the heart.
Effects like reduced cardiac output heart rate are largely indirect, stemming from coronary vasoconstriction, decreasing flow, and altered autonomic tone. In some patients with coronary insufficiency, even small amounts used for DI can paradoxically cause angina. Vasopressin-induced myocardial ischemia has rarely led to serious reactions, even death.
It also acts as a neurotransmitter in the CNS, influencing a surprising range of behaviors and functions.
Yes. Vasopressin functions as a critical neuromodulator in the CNS, though its full physiological significance is still being elucidated. It can modulate autonomic systems controlling heart rate, BP, respiration, sleep. While not the primary corticotropin-releasing factor, it plays a significant role in sustained HPA axis activation during chronic stress. Furthermore, extensive studies suggest vasopressin and oxytocin are key neurohormonal regulators of complex social and emotional behaviors. CNS effects of vasopressin seem predominantly V1-mediated, influencing aggression, pair bonding, social recognition.
And its role in blood coagulation is quite unique, therapeutically relevant.
Activation of V2 receptors by synthetic desmopressin or endogenous vasopressin significantly increases circulating factor VIII and von Willebrand factor. These crucial hemostatic effects are thought mediated by extrarenal V2 receptors on vascular endothelial cells, stimulating release from storage. Though the exact intermediate factors are likely complex, as direct application in vitro doesn't consistently cause release, suggesting an indirect in vivo mechanism.
Any other notable non-renal effects contributing to its overall profile?
At very high concentrations, vasopressin can stimulate uterine smooth muscle contraction via oxytocin receptors and GI tract contraction via V1, contributing to potential side effects like cramps. Vasopressin is stored within platelets, and V1 activation stimulates platelet aggregation. Lastly, V1 activation on liver cells stimulates glycogenolysis, contributing to glucose homeostasis, especially during stress.
Given this incredibly complex, vital vasopressin system, how do we strategically intervene therapeutically? Let's start by exploring the vasopressin receptor agonists mimicking or enhancing its actions.
There are naturally occurring vasopressin-like peptides, but in humans, 8-arginine vasopressin, AVP, is key. To enhance duration and receptor selectivity for clinical use, many synthetic analogs exist. Desmopressin, or DDAVP, is a synthetic analog representing a major therapeutic advance due to its remarkable V2 receptor selectivity.
Much more antidiuretic than vasopressor.
Hugely. Its antidiuretic to vasopressor ratio is 3,000 to 11,000 times greater than native vasopressin. Makes it the preferred, safest drug for treating central diabetes insipidus by minimizing unwanted V1 vasoconstrictor effects. It's important for elite understanding to remember vasopressin and oxytocin are structurally similar, so their agonists and antagonists can cross-react with each other's receptors to some extent. High doses might mimic or block oxytocin effects, and vice versa.
ADME, oral vasopressin inactivated.
Yes, oral native vasopressin rapidly inactivated by trypsin in the gut. Both vasopressin and desmopressin rapidly inactivated by peptidases, mainly liver-kidney. Native vasopressin has a very short half-life, 17-35 minutes, needing continuous infusion for sustained effects. Desmopressin, however, has a significantly longer half-life, 75 minutes to 3.5 hours, allowing less frequent dosing.
So what are the specific therapeutic uses, precisely categorized by V1 versus V2 effects? That functional distinction seems crucial.
Let's break it down. For V1 receptor-mediated therapeutic applications, mainly relying on its robust GI and vascular smooth muscle contraction, native vasopressin itself is the main agent. Vasodilatory shock, especially septic shock, is its only FDA-approved indication. In these patients, endogenous vasopressin is often inappropriately low, and they're highly sensitive to its pressor actions. Current septic shock guidelines typically recommend fluids and norepinephrine first, adding vasopressin as second line if needed. Its use in other shock states, hemorrhagic, cardiogenic, is more controversial.
Cardiac arrest, GI uses.
Vasopressin, sometimes with epinephrine steroids, showed some promise after in-hospital cardiac arrest in certain studies, but guidelines don't universally recommend it due to lack of consistent validation. Its V1-mediated GI contraction was historically used for postoperative ileus, abdominal distension, dispelling gas for X-rays. Its V1-mediated splanchnic vasoconstriction reduces portal blood flow, attenuating pressure bleeding in esophageal varices. While banning is definitive, V1 agonists can be used emergently until endoscopy, also used to reduce bleeding in hemorrhagic gastritis, burn surgery, other procedures.
Now, V2 receptor-mediated uses. Desmopressin is the star here. For water conservation, coagulation factors.
Exactly. Desmopressin is the standard, often life-changing drug, leveraging its potent water conservation and factor release. It's the standard drug of choice for central diabetes, insipidus, DI vasopressin deficiency. Polyuria and polydipsia are usually very well controlled, often needing lifelong therapy. Dosing meticulously adjusted to minimal effective amount, routes, intranasal, oral, subcutaneous 4. Native vasopressin itself is only for acute diagnostic use, not long-term DI therapy due to short duration and V1 side effects.
Bleeding disorders.
Desmopressin is invaluable. In most type I von Willebrand disease, VWD patients, some type 2 in VWD, it effectively elevates circulating VWF, and factor VIII shortens bleeding time, increases factor VIII in mild-moderate hemophilia A, critical for managing bleeding or prepping for minor surgery, notably effective in renal insufficiency, liver cirrhosis, drug-induced bleeding. However, tachyphylaxis decreasing response limits long-term continuous use.
Other V2 uses. Bedwetting, headaches.
Another significant V2 use is primary nocturnal enuresis, bedwetting. Bedtime desmopressin tablets give high response rates. Intranasal no longer recommended due to hyponatremia risk. And desmopressin can relieve post-lumbar puncture headache, likely by causing mild water retention, helping CSF fluid equilibration, alleviating low CSF pressure.
What about the most important toxicities and adverse effects and contraindications, especially that risk of water intoxication?
Most adverse effects, particularly with native vasopressin, are V1-mediated vascular and GI smooth muscle, much less common severe with V2 selective desmopressin. Large doses of native vasopressin can cause marked facial pallor, skin vasoconstriction, increased intestinal activity, abdominal pain, nausea, cramps, urge to defecate. Vasopressin must be used with extreme caution, if at all, in patients with vascular disease, especially coronary artery disease can precipitate arrhythmias, decrease cardiac output, even peripheral gangrene at high doses.
And the V2 risk, water intoxication.
The major, most dangerous V2-mediated adverse effect is water intoxication, hyponatremia, a significant, potentially fatal risk, potentiated by co-administering drugs enhancing antidiuresis or fluid retention, carbamazepine, chloropropamide, TCAs, NSAIDs, high-dose morphine. Conversely, lithium dimethylcycline, ethanol, can attenuate the response. Vasopressin agonists need extreme caution where rapid ECF volume increases pose risks: unstable angina, uncontrolled hypertension, decompensated heart failure, contraindicated in acute renal failure with oliguria. Patients getting desmopressin for hemostasis need careful fluid restriction to minimize hyponatremia. Strictly contraindicated in primary or psychogenic polydipsia, compulsive water drinking, severe hyponatremia would inevitably result.
Other side effects.
Mild facial flushing, headache common, especially with desmopressin. Allergic reactions possible. Intranasal use can cause local nasal effects like rhinitis, epistaxis.
Finally, let's explore vasopressin receptor antagonists, a more recent class often called aquaretics, targeted approach for water excess, hashtag G, vasopressin receptor antagonists, aquaretics.
Currently, the main ones in the U.S. are tolvaptan, a selective oral V2 antagonist, and conivaptan, a non-selective V1A-V2 antagonist, IV only. These drugs represent a targeted pharmacological approach to fluid balance by specifically modulating the vasopressin system.
What are their precise therapeutic uses, especially in managing that tricky hyponatremia, and how do they achieve their specific diuretic effect?
Aquaretics play a crucial targeted role managing hyponatremia, low serum sodium, especially when associated with conditions like CHF, cirrhosis, or nephrosis. In these states, low effective arterial blood volume often inappropriately stimulates vasopressin, leading to excess water retention relative to sodium, causing dilutional hyponatremia. They're also highly effective treating hyponatremia from SI-88 syndrome of inappropriate ADH secretion, where there's persistent, unregulated vasopressin release.
Their mechanism is just water excretion, not salt.
Their unique mechanism involves increasing renal-free water excretion, aquaretic action, with little or no significant change in electrolyte excretion. Key distinction from conventional diuretics causing natriuresis. Crucially, by antagonizing V2 receptors, they don't directly affect sodium reabsorption pathways elsewhere or stimulate TGF, thus avoiding associated GFR reductions seen with some other diuretics.
Tolvaptan specifics, polycystic kidney disease.
Tolvaptan is FDA approved for clinically significant hypervolemic and euvolemic hyponatremia. Beyond that, it also got specific FDA approval to slow kidney function decline in adults at risk of rapidly progressing autosomal dominant polycystic kidney disease, ADPKD. Conivaptan is approved for hospitalized patients with euvolemic hypervolemic hyponatremia. While V2 antagonists show short-term benefits improving decongestion and normalizing sodium in heart failure, this hasn't consistently translated into sustained improvements in critical outcomes like mortality or rehospitalization in major trials.
ADME tolvaptan half-life 2.8-12 hours, eliminated by CYP3A4. Conivaptan half-life 512, also metabolized via CYP3A, emphasizes drug interaction potential. What about the most significant toxicities, adverse effects, contraindications, paramount given risks of too rapid correction?
The most dangerous critical adverse effect is the risk of too rapid correction of hyponatremia. Can lead to devastating neurological complication. Osmotic demyelination syndrome, ODS, or central pontine myelinolysis can cause severe, irreversible neurological damage, potentially fatal. Tolvaptan carries a prominent black box warning for this. Therapy must be initiated and closely monitored in hospital with frequent serum sodium checks. Aquaretics should never be used concurrently with hypertonic saline.
Other effects from blocking V2.
Antagonism of V2 receptors inevitably causes polyuria. Can lead to increased incidence of dehydration, symptomatic hypotension, dizziness, thirst, xerostomia, dry mouth. GI effects like nausea, vomiting, constipation also possible. Tolvaptan has been associated with potential liver damage, especially long-term, so use for hyponatremia generally limited to 30 days. Avoid in liver disease. Both can cause headaches, hypokalemia, hyperglycemia, contraindicated in anuria, hypovolemic hyponatremia, need volume restoration, not reduction, and with co-administration of strong CYP3A4 inhibitors like clarithromycin, ketoconazole, significantly increases their plasma levels and toxicity risk. Tolvaptan might also increase hyperkalemia risk with ACE inhibitors, ARBs, K+ orodesparing diuretics due to effects on water excretion and downstream potassium handling.
We have truly journeyed deep into the microscopic, molecular, and physiological world of the nephron today, really peeling back layer after layer. We started by exploring how each intricate segment meticulously contributes to our vital fluid balance, understanding the why behind its design. We then unpacked the diverse, precise mechanisms of different diuretic classes, from subtle CAIs to powerful loops, everyday thiazides, protective K+ bearers, innovative gliflozins, intriguing natriuretic peptides, understanding their specific targets and broader systemic effects.
And finally, we meticulously demystified the complex vasopressin system, dissecting its hormonal symphony of synthesis and regulation, examining the targeted agonists and antagonists that precisely modulate water homeostasis, each with intricate mechanisms and critical clinical applications. You've gained, I hope, a comprehensive, expert-level understanding of how the kidney works and how these critical medications interact with its pathways to restore balance and treat a wide range of conditions, from fluid overload to severe electrolyte disturbances.
This isn't just a collection of facts. It's really a profound, integrated appreciation for the body's delicate internal environment and the cutting-edge science that safeguards it. You now possess a mastery of this topic that will serve you well, offering deep insights into one of the most fundamental aspects of human physiology and pharmacology.
As we conclude this deep dive, considering the incredible precision of the kidney's own regulatory feedback loops and the sometimes dramatic, sometimes subtle ways we intervene with targeted pharmacological agents, this raises an important question, I think. What does this level of detailed understanding truly tell us about the future of personalized medicine?
Right. Will we one day be able to fine-tune these interventions at an even more granular, perhaps single-cell level, minimizing side effects, enhancing our body's natural resilience even further beyond what we currently understand? The journey of understanding the human body is truly endless, and this deep dive is just another profound step in that fascinating exploration.
Thank you for dedicating your time to this deep dive with us.
We hope you gained invaluable insights and a deeper mastery of this critical subject. Until next time.